Hello everyone. So let's revise the respiratory physiology today in one shot. Okay. So I have written some facts. Okay, beforehand, so as to facilitate your learning. Okay. So respiration is the exchange of O2 and CO2 in the balance of O2 and CO2 in the body. Okay. It is external type or internal type. External respiration is for exchange. Concerned with the gases exchange, and internal is the utilization of O2 by the tissues for energy production. Okay. What are the stages? This is ventilation, transport and exchange. Ventilation refers to the stage in which there is exchange of gases. Transport is the stage in which the gases are transported, and exchange is the exchange between the gases, like O2 is given to the tissues and CO2 are brought by the from the tissues. Okay. So respiratory functions, we have the pH maintenance. The respiratory system has these functions. Okay. Then excretion of water vapor and acetones, the volatile substances like acetones. Your respiratory muscles are there which help in the laughing and singing. Okay. Then speech production, and a mechanism which increases the venous return, which expands the venous return, is a thoracic pump. Okay. This is also done by your respiratory system. And in non-respiratory functions, we have the surfactant production, is lecithin. Okay. Protein synthesis to maintain the structural framework. Okay. And the lungs secretes ACE, angiotensin converting enzyme. Okay. Which converts the angiotensin to 1 to 2. Okay. Which stimulates the aldosterone as it goes on. It also inactivates your bradykinin, serotonin and prostaglandin. These vasoactive substances. These three substances are called as vasoactive substances. Okay. These are called as vasoactive substances. So it inactivates the vasoactive substances, and lungs also secretes IgA. Okay. So we have the upper respiratory tract and the lower respiratory tract. We have in upper respiratory tract we have the nose, the glottis. Okay, these are not in sequence. Okay, don't mind this. So we have nose, glottis, pharynx, larynx, and your sinuses and all. In lower respiratory tract, we have your trachea, bronchi, and the lungs. Okay, lower respiratory tract. So upper respiratory tract is mainly doing the conditioning of air and removing the foreign particles. Okay, so we have the external layers, the nostrils. And if you go just a little deeper, then you have hair, so as to remove the foreign particles. Okay, and this is lined by ciliated columnar epithelium, and have the goblet cells that secrete mucus. Okay, and this nostrils have the this nostrils in the nasal canal has the function of warming and the purifying the air and bringing the air to the warm temperature. Okay, conditioning of the air to the room temperature, not the room temperature, the body temperature. Okay. Then we have pharynx. Pharynx is the common passage for food and air. We have nasopharynx, oropharynx, and laryngopharynx. Okay, nasopharynx is concerned with the respiration. Okay, and it is also lined with ciliated columnar epithelium and goblet cells. Isolated pockets of goblet cells are also present. Oropharynx is lined with a stratified epithelium. Okay, and then we have pharynx. From the pharynx we have larynx. Okay, larynx has the vocal cord which when vibrate produces sound. We have many laryngeal cartilages. Okay, the upper part of larynx is lined by a stratified squamous epithelium. Okay, and the lower part of the larynx is lined by a ciliated epithelium. Okay, now let's talk about the lower respiratory tract. Okay, so talking about the lower respiratory tract, we have the lower respiratory tract. Okay, lower respiratory tract. So we have, first of all, we have your trachea. Okay, we have your trachea or windpipe. Okay, from the larynx air enters into your trachea, and trachea is formed out of cartilaginous rings which are only anteriorly present. Okay, not posteriorly present. Okay, and these rings are made up of like the posterior part is of smooth muscles. Okay, so as to prevent the collapsing of the trachea. Okay, this C-shaped cartilaginous rings, okay, prevent the blockage of trachea. And trachea is also lined by a ciliated epithelium with goblet cells. Okay, ciliated epithelium. Then we have the bronchi. Okay, trachea divides into bronchi at the T5 level or your carina. This point is called as carina or your T5 level, where it divides into two bronchi. Okay, right and left. Okay, this is left bronchi, this is the right bronchi, which enters the respective lung, the left lung and the right lung. Okay, and there are no goblet cells and deep glands in the bronchi. Okay, and the bronchus which enters the lungs divides for about 20 to 23 subdivisions. Okay, 20 to 23 subdivisions. Okay, so the bronchus then divides into 20 to 23 subdivisions. okay, and the smallest division which forms is your bronchiole, okay, it is your bronchiole. And the last part of your conducting airway is called as a terminal bronchiole, okay, terminal bronchiole, okay, understood. So the terminal bronchiole, from here onwards the parts does the function of a gaseous exchange, okay. The terminal bronchiole, okay, terminal bronchiole. So terminal bronchiole is the end part, it's the end part of your conducting part, end part of your conducting system, okay, end part of your conducting system, okay. This is the end part of your conducting system, and this terminal up to the nose, from the nose to the terminal bronchiole there is no gaseous exchange, but after the terminal bronchiole gaseous exchange starts, okay. So terminal bronchiole divides into a respiratory bronchiole, terminal bronchiole divides into a respiratory bronchiole, okay, and respiratory bronchiole further divides into 6 alveolar ducts, and this each alveolar duct ends in a alveolar sac, okay, alveolar sac, and the wall of each alveolar sac, so let's say this is an alveolar sac, okay, and this is the alveolar duct, and this is the alveolar sac. So alveolar sac has grape like clusters which are called as, each one is called as an alveoli, okay, and the alveoli is the functional unit of gaseous exchange, functional unit of gas exchange, okay. So about there are 300 million alveoli in the adult lungs, okay. So this is done. Let me tell you that the bronchial tree, this is the bronchial tree which is rich in your elastic tissues, okay, and during expiration there is elastic recoil of the bronchial tree, okay. And about the lungs, if you want to know the functional anatomy of the lungs, so we have the right lung which is divided into 3 lobes, okay, 3 lobes, and your left lung which is divided into 2 lobes, okay, okay. Another clinical thing is that you have the trachea dividing into the bronchi and the lungs, okay. So here we have the left bronchi and the right bronchi, okay. So any chances of foreign body obstruction, in the chances of the foreign body obstruction, okay, it is more common in the right bronchi because the right bronchi is straight, and it is a bit short than the left bronchi, straight and short, but the left bronchi is a little bit curved, and as well as it is a bit longer, okay. So it is the right bronchi is more prone, so right lung is more prone to infections, okay, it is more prone to infections, understood. So let's talk about the blood supply and nerve supply of lungs, okay. So the conducting airway, the conducting pathway is supplied by your bronchial artery, okay, it is supplied by your bronchial artery, okay, and the respiratory part is supplied by the deoxygenated blood via the pulmonary arteries, and your respiratory part, okay, by the pulmonary arteries, okay, okay. And the nerve supply of the lungs, okay, the nerve supply of lungs, not the nerve supply of the lungs, but what nerves affect this. So we have the vagus nerve which gives parasympathetic stimulation, the parasympathetic stimulation, okay, and it causes a bronchoconstriction, okay, the bronchioles they constrict, okay, due to the parasympathetic stimulation, okay. About the covering of lungs, okay, the lungs are covered by the pleura, is the covering of lung, okay. Visceral pleura is attached to the lung, and parietal pleura just outside the lung. So this is the visceral pleura and this is the parietal pleura, okay, and the visceral pleura is attached at the hilum, okay, it is attached to the lung at the hilum, okay, and it completely covers the lung and comes back to hilum, okay, and then it forms a parietal pleura, okay. And the space between two membranes is called as the intrapleural space, which contains an intrapleural fluid, okay, and due to the hydraulic pressure of the intrapleural fluid, the pleural membranes are inseparable, okay. And here you have the surfactant present, okay, which provides the protection due to the friction, due to contraction and relaxation of the lungs, okay. You will have friction, so this is reduced by the pleural fluid, okay, this is the pleural fluid. And pleuritis, itis means inflammation, so pleuritis is the inflammation of your pleural sac, okay, understood. And let's discuss about another clinical which is called as a pleural effusion, Okay, pleural effusion. So pleural effusion is the collection of large amount of free fluid. Okay, if there is increased collection of fluid, okay, increased collection of fluid in the pleural space, okay, it decreases your gas exchange, it decreases your gas exchange efficiency, okay, efficiency, and this is called as pleural effusion. Okay, what are the causes? So cardiac failure may cause pleural effusion, cardiac failure may cause it, okay, and your reduced plasma colloid osmotic pressure, okay, reduced plasma colloid osmotic pressure, then blockage of lymphatic blockage, okay, lymphatic blockage, and any infection, okay, any infections, okay, which are causing damage to pleural surfaces. Okay, let's talk about the mechanics of breathing. Okay, let's talk about the mechanics of breathing. Okay, so in mechanics of breathing, we have three pressures which play important role. We have three pressures, okay, your atmospheric pressure, okay, and your intrapleural pressure, and again your intra-alveolar pressure. Okay, these three pressures are playing important role in your ventilation process, in your mechanics of breathing. Okay, so the two lungs are placed, you know, that either side of the heart in mediastinum, okay, and the lung is attached to the body at their hilum, okay, and the rest of the lung is free to move. Okay, when the thoracic cage expands, the parietal pleura is taken away. Okay, let's say if the thoracic cage is expanding, this is the thoracic cage which is expanding, okay, expanding. So thoracic cage is intrinsically connected to your parietal pleura, okay, let's say they are connected like this. This is a parietal pleura and they are connected like this, okay, and okay, if the thoracic cage expands, the parietal pleura is taken away. The parietal pleura is also taken away like this. The parietal pleura is taken away if it is expanding, okay, and due to this expansion, okay, parietal pleura is taken away, and visceral pleura is inseparable, okay, which also moves along, okay, visceral pleura also moves along, expanding, okay, and this causes the expansion of lung, okay, and this expansion of lung decreases the pressure of air in lungs, okay, due to which the atmospheric air will come into the lung, okay, and if the thoracic cage reduces in size, the parietal pleura and visceral pleura goes back, okay, so the lungs become smaller in size, leading to your expiration. Okay, so this is the mechanics of respiration, expiration and inspiration. Okay, understood. Then what are the muscles which are used in your for your normal respiration? Okay, so normal respiration uses your uses your diaphragm, which is the major muscle for normal respiration, okay, diaphragm, which causes a 75% of tidal volume. What is tidal volume we'll discuss. Okay, then your external intercostal muscles, okay, these external intercostal muscles help to increase the vertical and transverse as well as the anterior posterior diameter of your chest wall. Okay, this both muscles will increase your chest wall volume. Okay, chest wall volume. Understood. So this is for your normal tidal respiration, for normal respiration, diaphragm and EICM. Okay, let's discuss about the muscles of expiration. Then muscles of expiration. So for the expiration, okay, for expiration we have abdominal muscles. Okay, the rectus muscles. Okay, the abdominae recti muscles. Okay, rectus abdominis. Okay, recti muscles, and the transverse abdominis. Okay, the internal and external oblique muscles too. Internal oblique muscle and the external. This is external oblique muscles. Okay, so abdominal muscles increase your intra-abdominal pressure. Okay, this abdominal muscles, what they do? They are increasing your intra-abdominal pressure. They increase the intra-abdominal pressure. Okay, which will push the diaphragm and increase the intrapleural pressure also. Increase the intrapleural pressure. This increase in intrapleural pressure will cause the lungs to contract. Okay, the lungs will contract, and due to the contraction of the lungs, the air is moved out. which is called as your expiration. Okay, and all these muscles are accessory muscles because only during the tidal respiration the expiration is a passive process. Okay, these muscles are just helping for expiration. Expiration no matter is a passive process and inspiration is a active process. Okay, so these are your muscles for expiration. Okay, for inspiration we have accessory muscles also. Okay, for inspiration okay, for inspiration also we have accessory muscles. Which are accessory muscles? Your scalene muscles are there, your sternocleidomastoid is there. Okay, and your serratus anterior also helps, serratus anterior. Okay, these muscles help in the forced inspiration. Okay, these muscles help in your forced inspiration. Afterwards, let's discuss the mechanism of your normal tidal respiration. Okay, normal tidal respiration. But before that, just remember that the inspiration, the accessory muscles of inspiration, the scalene, sternocleidomastoid, and serratus anterior, in forced inspiration, this act by a mechanism which causes a bucket handle movement. Okay, it causes a bucket handle type movement. Okay, bucket handle movement. So they act via the bucket handle movement, which increases your transverse diameter. Okay, which increases the transverse diameter. Okay, let's discuss the normal mechanism. Okay, normal respiration. So how the normal inspiration occurs? For inspiration, first of all, the diaphragm is contracted. Okay, diaphragm is contracted. The diaphragm contracts. Okay, the diaphragm and your external intercostal muscles also contract. Okay, this both contract. Okay, all the diaphragm has a major role and about 90% role. EICM only have 10% role. Okay, due to this contraction, okay, all the three diameters increase, which will decrease your intrathoracic pressure, okay, and your intrapleural pressure. Okay, and due to this the air from the atmosphere will flow into your lungs. Okay, Okay, understood. Due to the pressure gradient creation. And expiration, the normal mechanism for expiration is that first it is a passive process. Okay, Okay, so due to this the all the inspiratory muscles, they relax. Okay, as they come from the contracted state, they will relax obviously. Okay, which will decrease the all the diameters. Okay, all the three diameters, and anterior, posterior, transverse, and the vertical diameter. Okay, which will increase your intra-alveolar pressure. Okay, and due to this increase in intra-alveolar pressure, the air will move out. Okay, air will move out due to the pressure gradient creation. Okay, so what is diaphragm? Diaphragm is a dome-shaped muscle. Okay, this diaphragm is a dome-shaped muscle like this. Okay, which separates your thorax and abdomen. Diaphragm is the point where this thorax and abdomen are separated. Okay, and more than 90% of the tidal inspiration is because of the contraction diaphragm only. Okay, due to the diaphragm contraction, this inspiration occurs. Okay, and the diaphragm also, it is said that the diaphragm it doesn't get fatigue. Okay, and the factors that are helping it to not get fatigue, okay, is that because only few muscle fibers in diaphragm contract. Okay, because only a few muscle fibers they contract. Only few muscle fibers contract. Okay, and other fibers are resting. Okay, understood. After that, let's know about the mechanism of the forced respiration. Okay, this was the normal mechanism, the normal respiration. Let's discuss about the forced respiration. So about the forced respiration, okay, forced inspiration, first one is the forced inspiration and the second one is the forced expiration. Okay, forced expiration. So forced inspiration is contracted like this, that your external intercostal muscle in diaphragm, and your external intercostal muscles, EICM, they contract more strongly, more powerful. Okay, they contract more powerfully. Okay, accessory muscles also contract, like your sternocleidomastoid, okay, and your serratus anterior, your scalene muscles, these also contract. Okay, these also contract, which add to this, and due to this the forced inspiration will occur, and forced expiration, how it will be there. Okay, here in forced expiration you will see the contraction of your abdominal muscles also, abdominal muscles. Okay, because in normal it was only the relaxation of inspiratory muscles, but here it is there will be the contraction of abdominal muscles, which will decrease the intra-abdominal pressure to a very much extent. Okay, which will decrease your vertical diameter as well as anterior posterior diameters. Okay, vertical diameter and decrease anterior posterior diameter. Okay, decrease anterior posterior diameter, and this will cause your expiration, forced expiration. Okay, understood? You know, intrapleural pressure is the pressure inside the intrapleural fluid. Okay, and intrapleural pressure can be recorded by inserting a needle into your intrapleural space. Okay, intrapleural pressure also reflects the esophageal pressure. Okay, as in you have to measure the intrapleural pressure, so you will just insert a needle inside. Okay, but this is a risky procedure. Okay, and intrapleural pressure also reflects your esophageal pressure. Okay, esophageal pressure, okay, is equal to your intrapleural pressure, physiologically intrapleural pressure. Okay, that's why what you do is that you put a balloon catheter into the lower part of esophagus via nostril. Okay, and another part you connect to a pressure transducer or the recording system. Okay, and then you can note. Understood? And importantly, just remember that the intrapleural pressure is always negative. It is always negative. Okay, it is always negative, and it varies from about -5 cm H2O during expiration. Okay, and it increases to, not increase, it decreases. Okay, because it is like in minus. Okay, it is increases in magnitude, but this decreases in your intensity. Okay, if the sign is concerned during inspiration. In inspiration, the intrapleural pressure, okay, it is decreasing. Okay, understood? And during forced breathing, okay, if you are like forced breathing, it will become more negative. Forced breathing, it will become more negative. Okay, and why it is negative? First of all, that why it is always negative. Intrapleural pressure is negative or subatmospheric. The sign is negative because you take the atmospheric pressure as 0. Okay, 0 cm H2O. Okay, and it is always less than the atmospheric, so it is a term negative. It is not negative absolutely, it is relatively negative. Okay, because the atmospheric pressure is taken 0. Okay, why it is negative? Because of the two opposing forces. Okay, because the normally your chest wall is pulled inward. Okay, and it constantly tends to pop outward. Okay, and lungs have a constant tendency to collapse. Okay, let's say here's the chest wall. Okay, and here's the wall of the lungs. Okay, so lungs have a tendency, here's the chest wall, and here's the wall of the lungs. Okay, so the wall of lungs has a tendency to be like collapse. Okay, lung has a tendency to collapsing tendency. Okay, due to this collapsing tendency, it tries to recoil from the chest wall. Okay, it tries to recoil from the chest wall, and the chest wall is constantly tries to pop outwards. It has the intrinsic tendency of popping. Okay, this will create a vacuum type of thing, a suction type of thing, and will cause the pressure to be negative. Okay, so these two forces, the equal and opposite forces, these are equal and opposite forces. Okay, this F1 and F2, so F1 and equal to F2, equal and opposite forces, cause the responsible for the negative values of your intrapleural pressure. Okay, understood? So after this, if your intrapleural pressure decreases, okay, if your intrapleural pressure decreases, it will favor inspiration. Okay. And another thing is a clinical thing, that is a barrel shaped chest. Barrel chest is caused if there is no intrapleural pressure. Okay, if there is loss of intrapleural pressure. Okay, intrapleural pressure. Understood. And another thing you have to note that if the intrapleural pressure becomes more negative, if there is more negative intrapleural pressure, your mediastinal pressure becomes negative also. Okay, because it is connected to the mediastinum. Okay, and this mediastinal pressure is negative, causing the expansion of large veins. Okay, the large veins, if the intrapleural pressure becomes more and more negative, it goes more negative. Okay, the large veins, they are basically relaxing. Okay, the large veins, they are basically expanding. Okay, which decreases the venous pressure. Okay, the venous pressure is decreased. Okay, and large amount of blood are sucked into the superior and inferior vena cava. Okay, which will increase your venous return. Okay, which will increase your venous return. Okay, and this is called as a respiratory pump. Okay, which is increasing your venous return during your inspiratory period, during your inspiration. Okay, during your inspiration. So increased venous return in during inspiration is produced due to your negative values of intrapleural pressure. Okay, and this increase in venous return also increases your cardiac output. This also increases your cardiac output. Okay, also increases your cardiac output. Okay. So respiratory pump is especially marked during the muscular exercises. Okay, if the intrapleural pressure becomes positive. Okay, if the intrapleural pressure becomes positive, like positive intrapleural pressure where it is seen. Okay, like if you do Valsalva maneuver, or if there is cough, very much cough, violent expiratory efforts are there. So there is positive intrapleural pressure, that will decrease your venous return. Okay, that will decrease your venous return, and this will decrease your cardiac output. This decreased cardiac output will cause your cerebral ischemia. Okay, and your visual blackouts. Okay, this all will cause. Okay, it is also positive during defecation. Just there's a fact given, is also positive during your defecation. Okay, or injury to chest wall. Okay, after intrapleural pressure, you can get a short note on intrapleural pressure, so you have sufficient content to write. Okay, let's talk about your intraalveolar pressure. Okay, intraalveolar pressure. Okay, intraalveolar pressure. Okay, intraalveolar pressure ranges from -1 cm of H2O to +1 cm of H2O. Okay, -1 cm during inspiration. During inspiration, it is -1 cm of H2O, and in expiration, it is +1 cm of H2O. Okay, and this change in intraalveolar pressure, okay, is helping in your movement of air. Okay, is helping in your movement of air. At the end of normal respiration, okay, it becomes 0 cm H2O at the end of your normal respiration. Okay, then if you run normal respiration, inspiration or expiration. Okay, understood. So then another pressure is there, which is called the transpulmonary pressure. Okay, transpulmonary pressure refers to your, okay, pressure inside the lungs, that is your intraalveolar pressure. Intraalveolar pressure minus your intrapleural pressure. Understood? So it is the pressure difference across your chest wall. Okay, and what is the significance? That it prevents lung collapse. Okay, and let's discuss about another pressure. Okay, which is across the lung wall. Okay, which is helping to hold the thorax and lungs in close approximation. Okay, which is called as your transmural pressure. Okay, transmural pressure, what it is trying to do, it is trying to holds thorax and lungs in close approximation, the thoracic wall and your lungs in close approximation. Okay, understood. Let's talk what is your airway resistance. Okay, let's talk about your airway resistance. Okay, talking about airway resistance, blood flow through any blood vessel depends upon pressure gradient and resistance offered by your vessel. Okay, so the blood flow through any vessel, blood flow depends upon your del P by R, where del P is the pressure gradient. Okay, this is the pressure gradient. Blood flow is represented by F. This is the pressure gradient, and R refers to your resistance. Okay, resistance. Okay, and the normal airway resistance, is 1.52 2 centimeter of H2O per liter per second. Okay, per liter per second. This is a normal resistance. Okay, if there is some disorders like your COPD is there, where obstructive lung disorders are there, where the resistance increases. Okay, due to blockage, resistance increases. Okay, and so if the resistance will increase, your blood flow will decrease. Okay, your flow will start decreasing. Okay, in your COPD cases. Okay, this is a clinical. So what is pneumothorax? Pneumothorax is a condition in which air is trapped. Okay, air trapping is called as your, in plural space is called as a pneumothorax. Okay, and due to this pneumothorax, what pressures are increased? This is important. Okay, due to pneumothorax. Okay, so which pressures are increased in your pneumothorax? Okay, so pneumothorax, in which the intrapleural pressure will increase. Okay, your intrapleural pressure. Okay, this will increase. Okay, because there is air accumulation in your intrapleural space. Okay, and the transpulmonary pressure. Okay, the transpulmonary pressure will decrease. Okay, transpulmonary pressure will decrease, which can lead to your lung collapse, because the transpulmonary pressure is maintaining your lung, preventing a lung to collapse. Okay, understood? And this pneumothorax can be caused due to many diseases, your respiratory diseases like your asthma or your COPD. Okay, this may cause this. Okay, and about the lungs are elastic in nature. Okay, why the lungs are elastic? Due to presence of elastin and collagen fibers. Okay, and these are distensible structures. Okay, and they have also the recoil tendency. Okay, they have also the recoil tendency. Okay, so a question comes that why the lung has recoil tendency. Okay, so lungs have recoil tendency. They have recoil tendency due to elastic tissues. Okay, one third of recoil tendency is due to elastic tissues. Okay, due to the presence of elastic tissues in the lungs. Okay, and another two third is contributed by a surface tension of the fluid. Okay, surface tension of the fluid lining the alveoli. Okay, okay, so this is the cause of a recoil tendency of the lungs. Okay, and the lungs recoil tendency is necessary because the lungs is like compressing and expanding. Okay, and this recoil tendency and the between both the lungs and the chest wall. Okay, it creates your negative intrapleural pressure also. Okay, and this surface tension, if you want to know what is the surface tension, this is the force minimizes the surface area at the interface. Okay, and this is caused due to unbalanced attraction of the surface molecules. Okay, and about one thing, let's discuss about a important topic, that is the compliance of the lungs. Okay, let's discuss about the compliance of the lungs. So lung compliance is the change of volume of lung. This is the change in volume of lung. Okay, change in volume of lung per unit change in your transpulmonary pressure, Okay, this is called as a compliance. Okay, for your lungs, the compliance for the lungs is 0.22 liter per cm H2O. 0.22 liter per cm H2O. Okay, but for the lungs plus your thorax, okay, the compliance reduces. This is about 0.13 liter per cm H2O. Okay, So just remember it. Okay. How can you measure the lung compliance? Okay. So for measuring lung compliance, for measurement, okay, you can use an intraesophageal balloon. Okay, you can use an intraesophageal balloon. Okay, intraesophageal balloon, and this is passed in a person for recording the intrapleural pressure. Okay. You know that I told that the intraesophageal pressure and the intrapleural pressure are equal. Okay, and at the end of each step, like the person is asked to inspire in steps. Okay, the person is asked to inspire in steps. Okay, at the end of each step, the pressure is recorded. Okay, these are plotted. They are plotted in the PV curve. Okay, these are plotted in your pressure against the volume curve. Okay, PV curve. Okay, expansion is such like that. Expiration is also done in steps. Okay, expiration is also done in steps. Okay, and these are also recorded in your expiratory compliance curve. Okay, and this slope of the PV curve, this will reflect your, the slope of the PV curve steepness will denote your compliance. Okay, understood? Okay, so if you want to see the curve, okay, generally the PV curve for your compliance for is okay. Let's define the compliance as, the compliance is defined as delta V by delta P. Okay, C equal to del V by del P. Okay, if the changes are small, dV by dP. Okay, and this dV by dP represents your slope, and the slope represents your compliance. So compliance is the slope of the curve. Okay, so it would be easy if you plot the delta volume, the lung volume change versus your pleural pressure, like pleural pressure in centimeter H2O. Okay, and this -4, -5, -6. Okay, I am drawing a curve which is given in a book. Okay, on inspiration this curve is like that, on inspiration the curve is like that. Okay, inspiration and expiration. Understood? So this is inspiration. Okay, this is your expiration. Okay, expiration curve. So there are two curves, your inspiratory compliance curve and your expiratory compliance curve, and these curves are obtained in a normal person. Okay, and this inspiratory compliance curve and expiratory compliance curve do not coincide. Okay, they do not coincide, and a loop is formed. This loop is called a hysteresis loop. Hysteresis loop. Okay, this is called a hysteresis loop. Okay, and this curve is reflecting the stretchability of lung in expiratory and inspiratory conditions. Okay, understood? So you know now the slope of the volume pressure curve indicates your compliance, and this is a static compliance. Okay, about the compliance of the thorax, you can calculate the compliance of the your thorax. Okay, the thorax has a compliance of your 0.11 per liter. Okay, 0.11 liter per cmH2. Okay, this is the compliance of the thorax. Okay, thorax, and the compliance of the lung and chest wall together. Okay, this is about 0.2 and 0.13. Okay, lungs and thorax, this is about 0.13. Okay, understood? And just remember that the compliance is max at your functional residual capacity of the lungs, FRC of the lungs. We'll see what is that. Okay, so the compliance which is measured at relaxation volume. Okay, the compliance which is measured at relaxation volume, that is FRC. Okay, so compliance at FRC, this is called as your specific compliance. Okay, specific compliance. So specific compliance is denoted as your compliance, okay, divided by your FRC. Okay, this is your specific compliance. Okay, specific compliance is your compliance divided by FRC. Okay, your let's say your FRC is 2500 ml. Okay, so your let's say compliance is your 0.2 liter per cmH2O. Okay, I am taking 0.20 in place of 0.22. Okay, in place of 0.22. Okay, then your specific compliance will come your 0.2 by 2.5, that is equal to 0.08 liter per cm H2. Okay, this. And just note that this compliance as the lung is at rest, okay, this compliance is called as your static compliance. This compliance is called as your static compliance. Okay, understood? And if one lung is removed surgically, okay, the compliance will become half. Okay, if there are two lungs here, okay, two lungs here, and if one lung removed minus one lung, okay, the compliance will be half. The compliance will decrease by half. It will be around 0.1 liter per cm H2O. Okay, understood? Then what is dynamic compliance? Okay, we talked about static compliance in this previous discussions. Let's talk about dynamic compliance. What is dynamic compliance? So dynamic compliance refers to okay, measured by recording continuous changes in intrapleural pressure and the lung volume. Okay, this is measured in real time compliance. Okay, this is measured in the real time. Okay, continuous changes are recorded continuously. It is measured continuous. Okay, and this is also more or less your same for your static compliance. Okay, but the dynamic compliance and static compliance, if you compare your dynamic compliance and static compliance, your dynamic compliance, your DC is always less than your static compliance. Okay, DC is always less than static compliance for lungs. Okay, for lungs it is this. Okay, but this dynamic compliance and static compliance are same. Okay, this dynamic compliance and your static compliance are same in the case of your thorax, for your thorax or the chest wall, you can say. Okay, chest wall. Okay, then what are the effects on compliance on diseases? Okay, so we can have two types of diseases. Okay, like your restrictive lung disease, okay, in which the compliance is decreased. Your restrictive lung disease compliance is decreased, okay, because due to infiltration of a non-elastic collagen, okay, the elasticity is decreased and your compliance is decreased. Okay, and in the diseases like your COPD, okay, in the diseases like your COPD, like your obstructive lung diseases, your compliance is increased. In COPD your compliance is increased. Okay, and emphysema, this is also a type of your COPD. Okay, it coexists with chronic bronchitis, and here also in walls of alveoli are progressively destroyed. Okay, so surface area is decreased. Okay, surface area for gas exchange is decreased, and the lung compliance it increases. Okay, understood? Okay, let's talk a little bit about your surfactant. You can get in short note on your lung surfactant. Okay, so this is a substance which can decrease your surface tension because of adsorption. Okay, because of adsorption, it is synthesized by your type 2 pneumocytes. Okay, type 2 pneumocytes. Okay, it is made up of it is called as a dipalmitoyl phosphatidylcholine. Okay, or simply your lecithin. Okay, simply your lecithin. This is a complex mixture of several phospholipids, proteins, and your ions. Okay, and this reduce the surface tension. Okay, and this also has some apoproteins, and your calcium is also present in this. Okay, which will help in the quick spreading of surfactant molecules. Okay, and the exact surface tension will depend upon the concentration and the orientation of the surfactant molecule on the surface. Okay, so the normal fluid that's lining the alveoli has a surface tension. If there is no surfactant, okay, then the surface area, the gaseous exchange membrane has a surface tension, okay, of 50 dynes per cm square. But if surfactant is present, if there is presence of surfactant, then it reduces to 5 to 30 dynes. Okay, 5 to 30 dynes per cm square. And the function is that the surfactant prevents the lung collapse. Okay, it prevents your lungs to collapse, prevent your collapse of lungs. Okay, by reducing the surface tension. Okay, it reduces the work of breathing. Okay, it reduces the work of breathing. it reduces work of breathing, and it brings in smoothness in breathing. Okay, that is it prevents the friction. Okay, and the surface tension will tend to collapse the alveoli and decrease the interstitial pressure. Okay, which can cause pulmonary edema. Okay, so surfactant molecule, what it does, the surfactant, this is reduce the surface tension, and this will decrease the inward force for drawing out fluid. Okay, decrease drawing out fluid, this is important, drawing out fluid from your capillaries, and thus it prevents your pulmonary edema. Okay, prevents your pulmonary edema. Okay, and it also gives your alveolar stability. Okay, okay, because there is instability in alveoli because of surface tension. Okay, so it gives your alveolar stability, is also used for alveolar stability. Understood? So because the alveolus has smaller diameter, okay, due to surfactant, the surface area is increased. Okay, so it maintains almost uniform size of alveoli. Okay, about pooling pressure of about 18 cm H2 is reduced to 4 cm H2 because alveoli has a intrinsic tendency to collapse. Okay, they have an inward pulling pressure. Okay, so due to lack of surfactant, if surfactant isn't present, it is about 18 cm H2, but in the presence of surfactant, it reduces to about 4 cm of H2. Okay, so this is the role of a surfactant. Okay, and there is a clinical associated with the surfactant. Let me tell you the clinical associated with the surfactant. So this surfactant, if there is no surfactant synthesis, okay, due to inadequate formation of your surfactant, okay, there is a disorder called as a neonatal respiratory distress syndrome, NRDS. Okay, increase in respiratory work and inadequate exchange of gases will occur. Okay, and pulmonary edema will occur. Okay, this leads to severe respiratory insufficiency. It is usually seen in your babies. Okay, babies like premature babies. Okay, premature babies in which the surfactant production hasn't been started yet, or it is insufficient now. Okay, so symptoms may start from the birth. Okay, this will lead to dyspnea. Okay, difficult breathing, and will also lead to tachypnea. Okay, as the lung is still struggling to take in water and all. Okay, and how can you treat the NRDS? So you can treat the NRDS by using CPAP. CPAP is continuous positive airway pressure. Okay, the like artificial respiration techniques are based upon your CPAP. Okay, and to prevent this NRDS, corticosteroids are given. The corticosteroids are given to the mother. Okay, corticosteroids are given to mother 1 day before delivery. 1 day before delivery. Okay, to stimulate the surfactant synthesis. Okay, and the fetal lung maturity can be checked by using a lecithin sphingomyelin ratio. So LS ratio is important thing. Lecithin sphingomyelin ratio, which is lecithin by your sphingomyelin. Okay, lecithin sphingomyelin ratio, and this is like if the ratio is normally 2:1. If it is less than 2:1, then this indicates there is decreased surfactant. Okay, and the fetal lung, if there is 2:1, then there is normal lung maturity. And if there is decreased, so there will be decreased surfactant production, that is there's less lung maturity. Okay, understood? Okay, so let's discuss about your airway resistance. Okay, and the work of breathing. Okay, we are still in the breathing mechanisms. Okay, the breathing mechanics. Okay, so airway resistance. Okay, airway resistance is provided by your walls of airways. Provide this resistance, and also this is caused due to friction of gas molecules, between themselves. Okay, so what factors will affect the airway resistance? So there will be greater the rate of gas flow, okay, greater the rate of gas flow, rate of gas flow, okay, is directly proportional to the airway resistance. Okay, then your airway diameter, okay, smaller diameter, greater is the resistance. Smaller diameter of your airway, okay, smaller diameter of your airway, greater resistance, greater airway resistance. Okay, and this smaller and greater diameter of the airways is called as a bronchoconstriction and bronchodilation. Okay, the sympathetic system causes a bronchodilation, so as to allow more oxygen into the body, and parasympathetic stimulation, the system causes bronchoconstriction. Okay, and about the length of the airway, it is also dependent on the length of the airways. Okay, length of airways, but it is not much significant. Okay, then let's discuss about the work of breathing. This is important, the work of breathing. Okay, work of breathing. What is the work of breathing? Work of breathing is the work, okay, work done by the respiratory muscles during the pulmonary ventilation. This is the work by the respiratory muscles, respiratory muscles. Okay, respiratory muscles. So work done is expressed, W is equal to pressure multiplied by volume, W equal to PV. We know this formula from our physics. Okay, so during a tidal expiration, no work is done, okay, because the muscles are relaxed. Okay, and the work of inspiration is divided into three fractions. Okay, so work of breathing may be divided into your work of inspiration, and your work of expiration. Expiration is a passive process, so there is no work done. Okay, it is a passive process, so work on W equal to 0. But work of inspiration, okay, there is a work of inspiration present. So work of inspiration is divided into three factors, that is the compliance work is the work required to expand the lungs, the work required that is used to expand the lungs, okay, against the chest elastic forces. Okay, this is equal to, okay, this compliance work is equal to delta P into delta V by 2. Okay, this is given by this formula, compliance work. Okay, another work is done which is called as a tissue resistance work. Your tissue resistance work, and another work is called as a airway resistance work. So what are these two? Your tissue resistant work is the work required to overcome the viscosity of lungs, okay, to overcome the viscosity of the lung. And this airway resistance work is to overcome your airway resistance, okay, respiratory pathways. Okay, so in a normal healthy individual, the lung are compliant and the airway resistance is also low. Okay, so about normal breathing requires about 3% of your total energy expenditure. So lung doesn't ask for more energy. Okay, normally your work of breathing is about 3% of total energy. Okay, 3% of total energy, the normal person. Okay, and what factors can increase the work of breathing? Okay, the factors that can increase the work of breathing. Okay, so the factors like a decreased lung compliance will increase breathing. Okay, as in pulmonary fibrosis like conditions. Okay, then increase airway resistance will also increase your work of breathing. So these factors are increasing work of breathing, which I am writing. Okay, decrease elastic recoil of lungs. Okay, like in emphysema, decrease elastic recoil as in emphysema. Okay, because the valves of alveoli are damaged. Okay, so more efforts are required. Okay, and increased ventilation. Okay, increased ventilation like your exercise, this will also increase your work of breathing. Okay, decreased compliance, increased airway resistance occurs in diseases like COPDs. Okay, COPDs and all, and asthma and all. Okay, so these factors will increase your work of breathing. Okay, let's go to another important part of this respiration chapter, that is your lung volume and capacities. lung volumes and capacities. Okay, what is pulmonary ventilation? It is the cyclical process, okay, by which the fresh air enters the lungs and equal volume of air is also exhaled. Okay, so volume of air given out or taken in during normal respiration is called as your tidal volume. Okay, so lung volume help to divide different volume of air functionally. Okay, so we have different lung volumes. Okay, we have different lung volumes. So lung volumes, maybe first one is the tidal volume, TV. TV is a volume of air or given or taken during a normal respiration, normal quiet respiration. Okay, and normal quiet respiration, this is about 500 ml. Okay, then you have the IRV, inspiratory reserve volume. It is the maximum amount of air that can be taken in. Okay, it is the maximum amount of air that can be taken in above the tidal volume. Okay, it is about 3000 ml. It is about 3000 ml. Okay, then you have the ERV, expiratory reserve volume. Okay, this is the maximum amount of air that is given, that can be expired, okay, above the tidal volume. And this is about 1100 ml, 1100 ml around. Okay, this also have ranges, but I am not telling you the ranges. I am giving the exact numbers so that it becomes easy to remember. Okay, then have residual volume also, some amount of air that remains in lungs even after forceful expiration. Okay, some amount of air remains in the lungs. This is called as RV. Okay, this is about 1200 ml. This is about 1200 ml. So these are the lung volumes. And about the capacities, we have many capacities, like inspiratory capacity, which is your tidal volume plus your inspiratory reserve volume. And if you sum this both, then you will get about 3500 ml. Okay, then your expiratory capacity is your tidal volume plus your expiratory reserve volume. Okay, this is about 1600 ml if you do the sum. Okay, and we have the functional residual capacity. Okay, functional residual capacity is the volume of air remaining in lungs after a normal tidal expiration. This is the volume of air remaining in lungs. Okay, remaining in lungs after a normal tidal respiration. Okay, and this is the formula is RV plus ERV. Okay, residual volume plus expiratory reserve volume. Okay, so this much volume of air remains in the lungs after a normal respiration. Okay, and this is about your 2300 ml, about your 2300 ml. Okay, and then we have the vital capacity of lung, where you sum the volumes, IRV plus TV plus ERV. Okay, the vital capacity of the lungs. Okay, that is the maximum amount of air that can be taken up after deepest possible inspiration. Okay, I told it wrong, that maximum volume of air that can be expired after deepest possible inspiration. Like you took the deepest possible inspiration, IRV. Okay, then tidal volume is there and you expire to the maximum. Okay, you inspire to the maximum as well as expire to the maximum. Of course, you will release the tidal volume in between. Okay, so this volume is your vital capacity, and this is about 4600 ml. Okay, and all the volumes of lungs, how they are recorded. Okay, these are earlier volumes and capacities, how they are recorded. Okay, this all volumes of lungs and capacities except the residual volume. Okay, your residual volume. Okay, your residual volume okay, your residual volume is except the residual volume. Okay, all are measured by your spirometer. Okay, spirometer. Okay, and as your residual volume is also present in your it is always present, it is already present. Okay, in FRC. Okay, so FRC also cannot be measured. So FRC is determined by your nitrogen. This is determined by your nitrogen washout method. Okay, nitrogen washout method, or this is also determined by your helium dilation method, or your helium dilution method. Okay, and we have the total lung capacity also, which includes all IRV, TV, ERV and your RV also. Okay, this is about this was 4600 and the residual volume is about 1200. Okay, 1200. So this is about your 5800 ml. Okay, 5800 ml. And this TLC also, total lung capacity, this also cannot be measured by spirometer. Okay. So this is also first your FRC is calculated by this nitrogen washout and helium dilution, and then your TLC is calculated by this. Okay. So what is spirometry? If I give you a basic just a basic idea about spirometry. So the spirometer, the instrument is called as a spirometer. So spirometer, basically it contains a drum. Okay, this contains a drum over an inverted chamber of water. Okay, we take a chamber of water and here is the water present. Okay, here's the water present and this is the drum. This is a floating drum. Okay, and in this floating drum, okay, this is like balanced by a weight here. Okay, this is balanced by some weight given. Okay, and let's take this weight. Okay, this is the weight, this is some weight given. Okay, and then it is connected to a recording drum. A drum is there in which the recording is there. Okay, recording drum. Okay, and here we have the water. Okay, and here you have the mouthpiece. You have the mouthpiece. Okay, mouthpiece for blowing of air. Okay, and the drum is filled with your oxygen. Drum is filled with your oxygen. It is connected to the mouthpiece for recording. Okay, the nose of the mouth, you close the nose by a nose clip and mouth clip is put into the mouth. Okay, it is put into the mouth, and the subject is connected to the spirometer. When the subject breathes in, okay, when the subject he breathes in, okay, the subject breathes in, then the air breathes in and out of the air chamber. Okay, the drum rises, and if the subject breathes out, the drum falls. Okay, by this rise and fall, okay, by this rise and fall, you can record your volumes and capacities as in a recording instrument, in the recording drum. So this is called as a spirometer. Okay, this is called as a spirometer. Understood? Okay. About a vital capacity. Vital capacity is somewhat very important or somewhat very interesting to know. Okay, this vital capacity, this is important. This is an important lung function test. Okay, it is influenced by factors like your position of the person. Okay, position of person. The vital capacity is more in standing. Okay, it is more in your standing position as compared to your lying down position. Okay, due to abdominal contents are pushing the diaphragm upwards. Okay, in lying down position, the abdominal contents will push the diaphragm upwards. Okay, which will decrease your VC in lying down position. Okay, in females, all the volumes or capacities are less. Okay, so in males the VC is more, and in your females the VC is less. Okay, so these factors affect your vital capacity. Okay, and based on your body build, okay, VC is higher in tall people. Okay, tall people, as tall and thin people as compared to a short and obese people. Okay, and about the compliance of the lung, in lung disease the compliance is reduced. Okay, so if the compliance is reduced, then the VC also reduces. Okay, like in lung diseases. Okay, and with age also it matters, like with age the VC decreases with age. Okay, because weakening of muscles will occur and elasticity of the lungs start to decrease. Okay, then we have a term called as FEB. So you can get a short note on FEB. FEB, that is called as a forced this is not FEB, sorry, this is a forced vital capacity. Okay, we'll discuss the forced vital capacity, where we'll discuss the FEB. Okay, this is the total amount of volume of air that is expired as forcefully, as quickly after possible after maximum inspiration. Okay, this is expired quickly. Okay, this is done quickly. Okay, and when we try to find out how much air a person is able to exhale as forcefully and as quickly with respect to time, we can get a forced expiratory volume also. We can get the forced expiratory volume, which is the short note question so I was telling about. Okay, forced expiratory volume. Okay, forced respiratory volume. So forced respiratory volume are They are denoted as FEV1 and these are FEV2. These are real time parameters, okay, FEV3 and so on. Okay, FEV1 refers to your volume of air that can be forcefully expired. Your volume of air that can be forcefully expired, forcefully expired, okay, in the first second. Okay, similarly this is the volume of air that can be forcefully expired in the second second. Okay, such you can calculate a FEB2, FE and FEB3. Okay, and the normal FEB1 is about 80%. Okay, normal FEB1 is about 80%. Okay, and the normal FEB1 by FBC, the forced vital capacity, is more than 70% at all cases in the just normal ratio. Okay, understood. So what's the significance is that in your COPD, in your obstructive lung diseases, in all your obstructive lung diseases like COPD, for example your COPD, okay, this FEV1 is reduced. Okay, FEV1 is reduced. Okay, so the ratio, your FEV1 by FBC, this ratio is decreased from 70%. Okay, and in restrictive lung disease, okay, in your restrictive lung disease, I will write from now onwards RLD and OLD. Okay, so don't get confused. In your RLDs, okay, like your pulmonary fibrosis, example is your pulmonary fibrosis. Okay, your both are reduced. Okay, this FEV1 and your FBC both are reduced. Okay, so ratio can be normal ratio, this ratio FEV1 by FBC. Okay, this either can increase from 70% or can remain equal to your 70%. Okay, this is the cases, this is the clinical significance of your FEV1. Okay, of your FEV1. Understood. So you can calculate, you can draw the graph here, like your if you get a short note, you can draw the graph and show the parameters also. Okay, let me show you in that graph. Okay, this is the lung volume change. Okay, this is the lung volume change. Okay, and let's say here is our ratios. Okay, is our ratios. Okay, so if this part, okay, this part at your first second, this is your time at the first second, this is the first second, this part is called as your FEV1, and this whole part is called as your FBC, your functional vital capacity, your forced vital capacity. Okay, and FEV1, and the percentage here is about 70%. Okay, then more than 70%, like 80% or so. Okay, but if there is airway obstruction, okay, if there is airway obstruction, the curve will shift a little. Okay, the curve will shift a little, and this FEV1 will start to reduce. Okay, in your obstructive lung diseases, the FEV1 starts reducing. Okay, and this will imply a obstructive lung disease. Okay, understood. So afterwards, okay, the we will discuss about expiratory flow rate. Okay, we will discuss about your expiratory flow rate. Okay, talking about expiratory flow rate, this expiratory flow rate, the normal expiratory flow rate, okay, this is about 400 liter per minute. Okay, it's about 400 liter per minute. Okay, so after deepest inspiration also, when one expires with a great force, okay, the expiratory flow rate reaches the maximum. Okay, this is the maximum. Okay, when there is forced expiration, okay, and there's forced expiration, it reaches the peak. Okay, it reaches the peak. Okay, and this is the normal values are about 400 liters per minute. Okay, and your your constrictive lung, obstructive lung diseases, okay, with the lung volume becomes smaller, and there is the reduction in the TLC and RV, okay. So this reduces the maximum expiratory flow rate, okay, in your lung diseases, okay, like in your restrictive lung diseases, okay. This what it will do, that the lung volume is reduced, which will reduce your TLC and your RV, okay. And due to some constriction or restriction, okay, in your constrictive lung disease, or you can say restrictive lung disease, constrictive, okay. So this will reduce your maximum expiratory flow rate, the EFR will be reduced. This is EFR, expiratory flow rate, understood. And in your long standing obstructive diseases also, this will also OLD, I am writing OLD, this will also decrease the EFR, okay, understood. So afterwards we'll see at the methods that are used to find out the FRC, okay. We talked about two methods, that is the first is a nitrogen washout method, okay. Let's talk about the nitrogen washout method, okay. These are the methods to find your functional residual capacity, okay. So first one is the nitrogen washout method. What do we do in this nitrogen washout method? At the end of a normal expiration, okay, the person is asked to inhale O2, okay. The person is asked to inhale the O2 for few minutes, okay. And during this, the expired air is collected. And analyzed for O2, okay. This is analyzed for your nitrogen, okay, N2, okay. And the FRC can be calculated by, FRC is the N2 content into 100 by 80, and FRC is equal to N2 content by 100 by 80, okay, understood, okay. Then you have the helium dilation method, okay. I am not going into details of these methods, okay. And then is the helium dilution method, method, okay. So first of all, you take a spirometer of known volume, okay. That is V1, okay. You take a spirometer of known volume, that is V1, okay. And you fill it with a mixture of helium and air at a known concentration, okay. This is a C1, this is the known spirometer volume. These are your known volumes, known spirometer volume, and this is the known concentration, known helium concentration, okay. And so amount of helium will be V1 into C1, or your C1 V1, okay. And the person is connected to the spirometer, okay. The person starts to breathe and the gases begin to mix with the lungs, okay. At the time, you can find the degree of dilution is determined by the finding out the concentration of helium in the spirometer, okay. After this person breathes, okay, the helium is diluted by your FRC, okay. And the helium does not leak out because it is closed, but the degree of dilution is determined by finding out the concentration of the C2 is the concentration of helium in the spirometer, okay. So final volume of helium will be C2V1 plus C2V2, okay. And this will be same as the final volume of helium, which will be same as initial volume, and the initial volume was C1V1, okay. So C2V2 plus C2V2, okay. C2V1 plus C2V2 equal to C1V1, okay. If you rearrange it, C2V2 is equal to C1V1 minus C2V1. So you can take V1 common, so C2V2 is equal to V1 into C1 minus C2, or you can write your V2 equal to V1 into C1 minus C2 by C1, okay. V2 equal to V1 minus C1 by C1, okay. And then what you can do is you can take this common as V2 equal to V1 into 1 minus C1 minus C2 minus 1. You can write this easily, okay. Just can you follow what I am saying? Okay, you can write this easily. And your FRC, which will be equal to your V2. Okay, so FRC. Okay, so you know all the concentration. Okay, FRC equal to V1 in bracket C1 by C2 minus 1. Okay, so you know the concentration of helium, you know the V1, you know the C1, and you measured the C2, so you know all the parameters and you can calculate the FRC by this formula. Okay, understood? So we wasted a few minutes on this calculation. I didn't want to tell you this all, but let's discuss so we can complain now. Okay, no problem. Let's talk about the respiratory minute volume. Okay, respiratory minute volume. About the respiratory minute volume, what is it? It is the volume of air. It is the volume of air that is taken in or given out per minute. Okay, per minute. This is important. Per minute during normal respiration, at the normal respiration. This is called as RMV, respiratory minute ventilation. Okay, and your maximum ventilatory volume, it is the maximum volume of air that can be taken in or given out per minute. Okay, so we have another term which is called as the maximum ventilatory volume, that is called as MBB. So what is MBB? It is the maximum volume of air. It is the max volume of air that can be taken or given out. Okay, per minute at normal respiration. Okay, understood? So it is approximately 120 liter per minute. It's approximately 120 liter per minute. And then you can calculate another parameter which is called as a breathing reserve. Which is BR. The difference between the MBB and respiratory minute volume, the RMB. Okay, MBB minus RMB, which so BR equal to MBB minus RMB. This is the formula. Okay, for calculating the breathing reserve. This formula is important. Okay, after discussing these things, let's talk about some dead space air. Okay, dead space air. Okay, this is the air which is not taking part in your exchange process. Okay, it is not taking part in an exchange process. This is of two types. We can have your anatomical dead space. Okay, and you can have your physiological dead space. Okay, anatomical dead space is the volume of air that fills the respiratory passage. Okay, it fills the passage from the nose to your terminal bronchioles. Okay, and this is anatomical dead space. In normal male, it is about 150 ml. Normal adult, it is about 150 ml. Okay, the physiological dead space is also called as your alveolar dead space. Okay, this is the addition of anatomical dead space, additional to anatomical dead space. Okay, and in normal, it is like sometimes few alveoli are not adequately perfused with blood. Okay, in this physiological dead space, okay, this can increase in various lung diseases, and your anatomical dead space is equal to physiological dead space in or let's say this anatomical dead space I am writing ADS, and physiological dead space PDS. ADS is equal to your PDS in your normal person. Okay, but ADS will the PDS will increase from the ADS in lung diseases. Okay, in lung diseases. Understood? So how can you measure the anatomical dead space? So anatomical dead space, this is measured by your single breath nitrogen washout test. Okay, this is also measured by your nitrogen washout test. Okay, the person is asked to inspire in pure oxygen. Okay, then he expires in the nitrogen meter. The nitrogen concentration is taken and the graph is plotted. Okay, so the formula is about it's a little bit complicated. You can get a graph on it. Okay, it is plotted like this. Just look at this phenomenon. Okay, this is the nitrogen percentage. This is nitrogen percentage which is plotted, and this is the air expired. This is the air expired. Okay, so if you plot the graph, you can get like this something. Okay, you can get some graph like this. Okay, if you see, this is a 500. Okay, 500 ml. This air expired in ml. This is nitrogen percentage. About some 50, about 55% of this is like the it is there 40, and this is 60. Okay, and you will see the graph will be like this. Okay, let this area be A, let this area be B. Okay, let this area be A, and let this area will be B. Okay, just I am not explaining, going to the details of the graph. It will take time to explain. Okay, just I am telling you how you can calculate by the formula. Okay, so BD, your dead space, this is the volume of dead space. Volume of dead space will be equal to your area A by area A plus area B, area A plus area B into VE. What is VE? Okay, what is VE? It is about your 500 ml. Okay, 500 ml. Understood? And if you calculate these areas, the area of A comes about around 30 cm square, and the area of B, this comes around 70 cm square. If you calculate the VD, okay, 30 by 70 plus 30 into your 500, so you get 105. So around 150 ml of anatomical dead space is there. This is for your anatomical dead space. And how you can measure your physiological dead space? This physiological dead space can be measured by your Bohr's equation. Okay, so it is based on the fact that your inspired air, it contains very less. It contains like very less CO2, almost zero CO2. Okay, so all CO2 in expired air is derived from your alveoli. Okay, alveoli. So how can you calculate it? You will do, okay, you will multiply the tidal volume into PCO2 in expired air. Okay, this will be equal to TB, tidal volume, minus X. Okay, X is the physiological dead space. Okay, into your average PCO2 in expired air. Okay, this is your average PCO2. Okay, plus X into PCO2 in inspired air. Okay, which is also 0. Okay, so there is no PCO2 in the inspired air according to Bohr's equation. So tidal volume into PCO2 is equal to tidal volume minus X into your average PCO2 in expired air. This is the whole equation, okay, which is called as your Bohr's equation. Understood? This is the Bohr's equation for measurement of your physiological dead space. Okay, so we just done like this. Okay, so we did this. After this, let's talk about your alveolar ventilation, your alveolar air. Okay, your alveolar air is equal to your tidal volume minus your dead space air. Okay, this is equal to like 500 minus 150 is equal to 350 ml. Okay, so alveolar air is also ventilated. Rate at which alveoli is ventilated per minute. Okay, rate at which alveoli ventilated. Okay, this is the rate at which the alveoli is ventilated per minute. This is called as your alveolar ventilation. And alveolar ventilation is about 350 ml. Okay, 350 ml into 12. Okay, about 4.2 liter per minute is the rate of your alveolar ventilation. This is about 4.2 liter per minute, and this air will take part in a gaseous exchange. Okay, well, pulmonary ventilation, we have the pulmonary ventilation also. Pulmonary ventilation is the product of tidal volume into your respiratory rate. Okay, about 500 into 12, about 6 liters per minute. Okay, and alveolar ventilation is less than your pulmonary ventilation. Okay, why it is less? Because your alveolar ventilation is less due to your dead space here. Okay, it is less due to your dead space here. Okay, and the alveolar air, about what is the difference between alveolar air? This is the alveolar air, and this is the atmospheric air. This is atmospheric air. Okay, so in alveolar air there is less PO2 concentration, there is less O2 concentration, and there is more CO2 concentration, okay, due to which the respiration occurs. Okay, and in each, while passing through respiratory passage, air it's humidified. Okay, so there is a pressure difference created in this alveolar air and between the atmospheric air. Okay, understood. Let's talk about your pulmonary circulation. Okay, the pulmonary circulation and your ventilation perfusion ratios and all. Okay, let's discuss about your pulmonary circulation. And talking about pulmonary circulation, the deoxygenated blood from the right ventricle, okay, from the right ventricle it passes to the lungs, via pulmonary artery. Okay, then in lungs it is oxygenated by the pulmonary capillaries, which by the pulmonary vein. Okay, this lungs from the blood from the lungs is carried on to the left atrium. Okay, so pulmonary blood flow is almost same as the cardiac output from the left ventricle. Okay, your pulmonary blood flow, this is an important fact, that the pulmonary blood flow is equal to your cardiac output from left ventricle, from your left ventricle. Okay, so this is an important fact. What is the pulmonary gaseous exchange method? Okay, so you just know that oxygen will enter at the alveolar capillary interface. Okay, then transform into dissolved form or in bound form to the bound to the hemoglobin. Okay, the oxygen will diffuse into the cells and the cells will utilize it. Okay, and CO2 will diffuse out and transform into dissolved form. Okay, bound to hemoglobin or bicarbonate. Okay, and CO2 will again enter your alveoli. Okay, and we breathe out your CO2. Okay. About a pulmonary circulation, let's discuss the facts about pulmonary circulation. You can get a short note. Okay, you can get a short note. Okay, let's discuss about it first. Let's discuss about the compliance of the pulmonary system, pulmonary vessels. Okay, so pulmonary arterial system is thin walled and distensible. Okay, so your pulmonary artery has large compliance. It has a large compliance. Okay, large compliance of around 7 ml per mmHg. Okay, this is which is the compliance of the entire systemic tree. Okay, combined. Okay, so the pulmonary veins are like as distensible as the systemic veins. Okay, about the pressure, about compliance we talked. About the pressure changes. Okay, in pulmonary artery, your systolic pressure in pulmonary artery, your pressure is about 25 mmHg. Okay, and diastolic is your 8 mmHg. Okay, and a pulse pressure, you can calculate the pulse pressure. The pulse pressure will be 17 mmHg. Okay, and the mean pressure was 15 mmHg. Okay, mean pressure is about 15 mmHg. Your pulmonary capillary pressure is about 7 mmHg. And your pulmonary vein, okay, is about 2 mmHg. Okay, about the blood volume, the quantity of blood present in the lungs. Okay, talking about a blood volume. Okay, how much quantity of blood is present in the lungs? So in the lungs about 225 to 900 ml of blood is produced. Is present. Okay, and your blood flow to the lungs is equal to your cardiac output. I told this fact earlier. Okay, this fact is important. Pulmonary blood flow is equal to your cardiac output from your left ventricle. Okay, cardiac output from your to your left ventricle. Understood? And in standing position, your arterial pressure is like in your uppermost portion of lungs, it is 15 mmHg less than the pulmonary arterial pressure at level of the heart. Okay, the pressure in the lowermost portion of lung, it is about 8 mm greater. Okay, so in standing position, the pressures are different. Okay, this pressures which I told is in your recumbent position, but in standing position, if you stand, in the standing position. If this is the lungs, this is the apex of the lungs, and this is the base of the lungs, okay, in standing. So what happens in standing position? Arterial pressure in uppermost portion of lungs is in the uppermost portion of lungs, it is about, okay, the pulmonary arterial pressure is about 25 mmHg. So it is less by 25 minus 15 mmHg less, okay, it is about 10 mmHg, okay. And the in the lowermost portion of the lungs, okay, it is greater by 8 mmHg, okay, 25 plus 8, okay, this is about 33 mmHg, okay, 33 mmHg, lowermost part, and the uppermost part, okay. Then what is the distribution of the pulmonary blood flow? Okay, what is the distribution of the pulmonary blood flow? About the distribution, okay, there is decreased blood flow in the upper part of lungs, and about greater blood flow in the lower part of lungs due to decreased pressure. Due to this decreased pressure, there is decreased blood flow also, okay. This is decreased blood flow. Then there is decreased blood flow, and due to more pressure there is increased blood flow in this upper part of the this is in the lower part of the lungs, okay, understood. So lungs therefore has a 3 different zones of blood flow, okay. The zone 1, okay, the zone 1 is the no blood flow at all during any part of cardiac cycle, because the capillary pressure is about it is less than your alveolar pressure, okay. And zone 2, in zone 2 there is an intermittent flow of blood in the systole, okay, as pulmonary pressure rises above the alveolar pressure, okay. And the zone 3 there is continuous blood flow. Zone 3 that is there is continuous that blood flow, okay. What I am talking about, just leave out the zones, okay. A normal lung has about 2 zones, okay. If I am leaving out the zones, okay, and there is this is called as a zone 2 of lungs. I am talking about a normal lung. This is called as zone 2, and this is called as your zone 3 of lungs, okay. So zone 2, so in upright position there is intermittent flow of blood. So in upper part of lungs there is an intermittent flow of blood, okay. And the lower part of lungs, in the lower part of lungs there is a continuous blood flow, okay, continuous blood flow, okay, understood. Okay, so after this, okay, let's discuss the capillary exchange of fluid in the lungs, okay. The fluid outside the alveoli is also controlled by the Starling forces, okay. I'm not going into that, okay. So let's not discuss the Starling forces and the capillary dynamics, okay. The capillary pressure is about 7 mmHg, and your fluid osmotic pressure is about 14 mmHg, okay. And outward pressure is about 29 mmHg, and so net filtration pressure is about 29 minus 28, 1 mmHg, okay. We'll not see that point, okay, understood. So after that, after doing this, let's discuss about a fact which is called as a pulmonary edema. Pulmonary edema is the accumulation of fluid in the lungs, okay. Pulmonary edema, okay, this causes a pulmonary edema, and this pulmonary edema will reduce your lung compliance, okay, and this will cause a poor ventilation. This causes a poor oxygenation, and ventilation perfusion mismatch will occur, okay. The person present with dyspnea and tachypnea and hypoxemia, okay, understood. So after this, if the pressure, unless the pressure in pulmonary capillaries rises approximately to the colloid osmotic pressure of the blood, okay, pulmonary edema does not develop. What I am telling, if the pressure in the pulmonary capillary, if there is increased pressure in pulmonary capillary, okay, which increases up to which is greater, let's say this is called as a PC, okay. If the PC is greater than the colloid osmotic pressure of blood, then only you develop pulmonary edema. Okay, pulmonary edema. Like the pressure in the your pulmonary capillaries, okay, the pressure in the pulmonary capillaries is normally a 7, okay, and the COP of blood in normal, this is the normal, okay, and the COP of blood is normally 28, okay, 28 mmHg, 28 mmHg. So if there is if the pulmonary capillaries, okay, they increase up to 28, okay, the pressure increases up to 28, then there will be pulmonary edema. So 28 minus 7, that is 21 mmHg, 21 mmHg. This is called as a safety factor. This is called as a safety factor for pulmonary edema, okay. This is a safety factor for your pulmonary edema, okay. Let's talk about pulmonary embolism. Embolism is the blockage in the pulmonary artery system. This is a pulmonary artery, so if there is any blockage, this is called as a pulmonary embolism, okay, embolism. So it may get lost and transported into deep veins of the legs in the saphenous vein and all, okay. This will decrease the diffusion, decrease the diffusion area of lungs, okay. This will increase your dead space, okay, and it will cause your pulmonary hypertension, and it will lead to death ultimately, okay. And you can treat this by dissolving this clot. You can prescribe your thrombolytic agents and anticoagulants to describe this, to dissolve this clot, okay. Understood? So if the blood is flowing in the pulmonary capillary, okay, in the pulmonary capillary blood, pulmonary capillary blood, it has a PO2, about 40 mmHg, and PCO2 is about 45 mmHg in your pulmonary capillary blood. So this is important, okay. Let's discuss about the very important VQ ratio, okay. Let's discuss about the VQ ratio, okay. This is called as your ventilation perfusion ratio, or also written as your VA/Q ratio, okay, or VA/Q ratio, okay. And how much is the normal ratio? So it is the ratio of your alveolar ventilation per minute by your amount of blood, the blood supplied to lungs, okay, per minute, okay. So if you cut the minutes, so alveolar ventilation by your blood flow to lungs, okay. This is about alveolar ventilation per minute about 4 liters, okay, and your blood flow to lungs is about 5 liters. So it comes about 0.8, it comes near 0.8, okay. So 0.8, it is the normal VQ ratio, okay. There is an increase in VQ ratio. VQ ratio is clinically significant, okay. There is increase in ratio, okay. First of all, let's see the differences in the apex and the base of the lungs only, then we'll see about the pathological states, okay. So if this is the lung, this is the apex of the lung, and this is the base of the lung, okay. In the apex of the lung, the VQ ratio is high, the VQ ratio is very high, and the base of the lung, the VQ ratio is low. Why the VQ ratio is low? Because in the there is more blood flow. Where? Because there is continuous blood flow in the base, okay. There is more blood flow. If this increases, the VQ ratio will decrease, okay. But in the apex of the lung, there is intermittent blood flow, so Q is less. So if Q is less, then your ratio will increase, okay. The VQ ratio, it is more in the apex and it is less in the base of the lung, okay. This is an important statement, okay. So afterwards, let's discuss the pathological states, okay. If the VQ ratio is increased, okay, increased VQ ratio. Increased VQ ratio means there is more ventilation. There is more ventilation, okay. There is more ventilation as compared to your blood flow, okay, because this will cause, due to extra air, okay, this will contribute to your alveolar dead space formation, okay. Extra air will cause alveolar dead space formation, so the alveolar dead space, will increase, okay. The air will not be utilized for gases exchange, okay, and the composition of your alveolar air will it will change, okay. Understood. So what are the effects? What are the effects of increased VQ ratio? Increased VQ ratio will lead to decreased exchange gases, decreased exchange of gases, decreased exchange of gases, and this will lead to an alveolar dead space formation and the change in alveolar air composition, okay. Let's take what do you mean by decreased VQ ratio? If the VQ ratio is decreased, so there is more blood flow, as compared to your ventilation, okay. So the part of blood remains deoxygenated as there is no ventilation, okay. Blood flow is occurring but ventilation is not occurring, okay. So there is an accumulation of deoxygenated blood, okay, which is called as your shunted blood, which will be called as your shunted blood, okay, shunted blood. Understood. This shunted blood plus the additional blood flowing through your bronchial vessels, this shunted blood plus your additional blood through bronchial vessels, forms your physiological shunt mechanism, okay. If the blood is bypassing the lungs because of this anatomical defects, it is called as an anatomical shunt, which is not a concept of discussion here, okay. And what will be the effects of the decreased VQ ratio? Due to decreased VQ ratio, there is decreased exchange of gases, decreased exchange of gases, there will be shunting, and the change in alveolar air composition will also occur here, okay. Let's say what is the meaning when you say that the VQ ratio is 0. That means that your ventilation is not occurring, okay. Ventilation is not occurring, okay. And the air in alveolus, there is this alveolar air, and the alveolar air PO2 and PCO2 will be equal to your venous blood, okay. So there is no exchange of gases, no exchange of gases will be occurring, okay. This is called as your zero VQ ratio, okay. This is a zero VQ ratio. Understood. So here what will if there is zero VQ ratio, okay, the PO2 will be 149 mmHg, okay, and your PCO2 will be your 0 mmHg, okay. This will be the fact, okay. So let's see this, okay. Let's look at this statements again. So just look at this notes here, okay. So VQ ratio, as I told, it is more in the upper part of lung. So VQ ratio is about 3.3. It is about your 3.3 in your upper part of lung and about 0.6 in the lower part of lung, okay. If the VQ ratio is normal, the alveolar air PO2 is 100, PCO2 is 40. If the VQ ratio is 0, the PO2 will be 40, PCO2 will be 46, okay. There will be no ventilation, okay. So VQ ratio is 0, it is just similar to your venous blood, okay. And this occurs due to obstruction of foreign body lodging and tumors, okay. Foreign lodging or tumors. Understood. And VQ ratio infinity means there is no perfusion. In case of embolism, the VQ ratio can become infinity, okay. VQ ratio can become infinity. Understood. So this was about the VQ ratio. Let's talk about the COPD. Okay, so COPD is within your syllabus, it is a CBME curriculum. It is a group of lung disorders. You can get a short note on this. It is a group of disorders, okay. It's a group of disorders which will show increased airway resistance, okay. And the diameters of your airways are decreased, diameter of airways are decreased, okay. Decreased diameter of airways, okay. And the patient have to work hard to breathe, okay. So there is increased work of breathing, okay. And COPD comprises of disorders like your bronchitis, chronic bronchitis, okay. And your disorder called as your asthma and your emphysema, okay. So what is chronic bronchitis? Bronchitis is the inflammation of your lower airways, okay. This is the inflammation of lower airways, okay. The causes may be due to smoking, okay, smoking, pollution, okay, smoking, pollution, or irritants, okay, irritants. Understood. So the patient is also prone to bacterial infections. Okay, there is inflammation. There is edema. Okay, there is edema, and thick mucus is produced. And all. Okay, what is asthma? Asthma is the airway obstruction. Okay, due to the thickening of the respiratory airway walls. Okay, it is caused due to bronchoconstriction. Okay, because the bronchi are hyper responsive. Okay, they're hyper responsive, so they are more responsive to your bronchoconstriction. Okay, there is plugging of airways, there is plugging of mucus plug. Okay, plugging with mucus, there is a mucus plug. Okay, and the symptoms will include symptoms like wheezing, okay, breathlessness, okay, and cough. This all, okay, this will occur. Okay, and this asthma is characterized by a spastic contraction of a smooth muscles. Okay, if you in the bronchioles, it is lined by a smooth muscles. These are just smooth muscles. So there is the spastic contraction of the smooth muscles, which will cause the difficult breathing. Okay, common cause is the contractile hypersensitivity. Okay, the most common cause is the contractile hypersensitivity to various foreign substances. Okay, so there is localized edema, so bronchoconstriction, and there is edema in small bronchioles. Okay, and there is spasm of your smooth muscles. Okay, there is spasm. Okay, there is bronchospasm. This is called as bronchospasm. Okay, there is difficulty in expiring and then inspiring the air. Okay, and the chest will also become your barrel shaped. Okay, we'll see your barrel chest in asthma cases. Okay, then after emphysema. Okay, let's talk about your emphysema. So emphysema is causing an increased airway obstruction. Okay, this emphysema is due to your chronic exposure to lung tissue to smoke. Okay, about smoke and irritants that can cause release of your trypsin. Okay, trypsin from your alveolar macrophages. Okay, and this trypsin is a protein digesting enzyme. This trypsin can break down. This can what can do? It can break down the alveolar walls. Okay, and collapse the small airways. Okay, collapse your small airways, which will lead to your emphysema. Okay, understood. And what will be the effects of emphysema is that there will be increased airway resistance. In emphysema, there will be increased airway resistance due to bronchial obstruction. Okay, due to loss of alveolar wall, there is decreased in diffusing capacity. Of lung. Okay, and abnormal VQ ratio. Okay, abnormal VQ ratio will occur. Okay, so due to the pulmonary vascular resistance, also due to decrease in number, the resistance increases. Okay, if the resistance increases, there will be more strain, causing a pulmonary hypertension. Okay, pulmonary hypertension also. Understood? Okay, so afterwards, let's discuss the respiratory membrane and the factors affecting the diffusion. Okay, the factors affecting the diffusion of lungs. Okay, let's start it. So let's talk about a respiratory membrane. So here's the respiratory membrane. Okay, and the respiratory membrane. Okay, the membranes of respiratory bronchioles, alveolar ducts, and alveoli, where gaseous exchange is taking place, is collectively termed as a respiratory membrane. Okay, it has a surface area of 70 meters square. Okay, and the total quantity of blood at any given instance in a lung capillaries is about 60 to 140 ml. Okay, so the blood spreads over a large surface area. Okay, The thickness of the respiratory membrane, this is the respiratory membrane. If this is the respiratory membrane, the thickness is about 0.6 millimeter. 0.6 millimeter. So what are the layers? Okay, first of all, the layer of fluid lining the alveolus, okay, with surfactant. Okay, this is your area of fluid, that is this one. This one is the surfactant layer. Okay, surfactant layer. This is also contributing to a respiratory membrane, a surfactant layer. Then second one is your alveolar epithelium. This is the alveolar epithelium. Okay, then you will have the basement membrane. Of course, if you have epithelium, you will have the basement membrane. Okay, so we have alveolar basement membrane. Okay, and the interstitial space here, there is an interstitial space present here. Okay, this is called as your interstitial space. Okay, and your capillary basement membrane and your capillary endothelium. Capillary basement membrane, and sixth one will be your capillary epithelium, which is called as your endothelium. Okay, so this O2 and CO2, this both are lipid soluble gases. This O2 and CO2, this both are your lipid soluble. These are your lipid soluble, so they can easily pass through the cell membrane. Okay, and it is just like your diffusion, so it just moves by diffusion. Okay, and the factors affecting your gaseous exchange, okay, so you have around 5 factors which will affect your gaseous exchange. So we have factors, let's say this is gaseous exchange. So you have around 5 factors affecting it. So first factor is the thickness of respiratory membrane. Okay, thickness of the respiratory membrane. So rate of diffusion is inversely proportional to the thickness of the respiratory membrane. Okay, so thickness is inversely proportional to the gaseous exchange. GE, I am writing GE for gaseous exchange. Okay, more thickness, more the less the diffusion. Okay, then the surface area, the rate of diffusion is directly proportional to the surface area. So surface area is directly proportional to the gaseous exchange. More the surface area, more gaseous exchange. Okay, more the surface area, more your gaseous exchange. Okay, and like in obstructive lung diseases, okay, with the air gets trapped in the alveoli and makes them larger, reducing the surface area in obstructive lung diseases. Okay, so if the surface area is reduced, then the gaseous exchange is also reduced. Okay, gaseous exchange is also reduced. Then it also depends upon your diffusion coefficient. As it is diffusion, so it also varies with the diffusion coefficient. Like your diffusion coefficient of CO2, okay, dCO2 is about 20 times more, of DO2. Okay, so CO2 has more affinity, okay, towards your RBC, your oxygen and all. Okay, then your pressure gradient, it also depends upon your pressure gradient. Okay, in your alveoli, in your alveolar air, the PO2 is about 104 mmHg, and of blood it is about your 40 mmHg. Okay, so the gradient created is about your 64 mmHg. Okay, this is the gradient. Okay, so 64 mmHg. Okay, so the average pressure gradient for O2, the average, if you take the average, it is about 11 mmHg. Okay, for CO2 it is about 1 mmHg. Okay, and so as PCO2 is higher in the blood than in alveolar, okay, it diffuses from blood to alveoli. Okay, so it depends upon the pressure gradient also, and also it depends upon the VQ ratio. Okay, at normal VQ ratio, if the VQ ratio is normal, there is max gaseous exchange. Okay, and if there is change in any VQ ratios, then the gaseous exchange will vary accordingly. Okay, it will decrease. Okay, and which disorder will influence the diffusion of gases? Like if there is thickness of respiratory membrane, if there is more thick respiratory membrane, okay, for example in a pulmonary edema, okay, like in a thickness increases in a pulmonary edema, okay, edema. So there is decrease in gaseous exchange, the gaseous exchange will decrease. Or if there is some disorder which will reduce the surface area, okay, reduce the surface area, like emphysema. Emphysema will reduce the surface area, okay, reducing the surface area will reduce the gaseous exchange, okay. So these are important likewise. Understood? Okay. Okay, so another term is there which is called as your venous admixture. Venous admixture. So what is venous admixture? Is that it is the your PO2 in your pulmonary capillary. Okay, PO2 in the pulmonary capillary is about 104 mmHg. Okay, 104 mmHg. But the PO2 in your arterial blood is about 97 mmHg. Okay, so there is lower systemic arterial PO2 due to the venous admixture or due to the mixing of the venous blood. Okay, because your 2% of about 2% of blood from a systemic venous blood, okay, from your venous parts, okay, 2% venous blood, okay, it gets mixed with your pulmonary capillary blood. Okay, understood? So we have the diffusing capacity of lungs for a given gas. It is specific for a given gas, because the amount of gas that diffuses through the respiratory membrane. Okay, the like say this is a respiratory membrane, okay, the amount of gas, let's say x amount of gas is diffused, okay, it is diffused respiratory membrane per minute, okay, diffused per minute per mmHg pressure gradient, okay. This is called as the diffusing capacity of the gas. So x is called as the diffusing capacity of lungs for the gas, okay, capacity of lungs for the gas, okay. Understood? After this, how you can measure this? So you can measure the diffusing capacity of CO. Okay, so we know the diffusing capacity of CO, okay, and the diffusing capacity of CO can be measured. The diffusing capacity, the DC of carbon monoxide, is about 1.23, okay, and the diffusing coefficient O2 is about 1.23, the diffusing capacity of CO, okay. So you can measure this, okay. Understood? Just cut this fact. There is an improvisation here, okay. So you can calculate, just simply remember that the diffusing capacity, okay, DC of O2 can be measured by 1.23 into, okay, this can be measured by 1.23 into diffusing capacity of CO, carbon monoxide. So this can be measured, diffusing capacity of CO can be measured, okay. So why diffusing capacity of CO is used for this measurement? Okay, because if CO gas, when CO gas is used, okay, the pulmonary blood, okay, PCO can be considered as 0, okay. So as CO combines with hemoglobin very rapidly, okay, and the pressure of CO is not built, okay, it doesn't allow the pressure of CO to build up in the plasma, okay, it is not built, okay. So the use of CO avoids the need of collection of pulmonary capillary blood. Okay, pulmonary capillary blood difficult to collect, okay. So you can collect any other blood for the estimation of O2 in your pulmonary capillaries, okay, because the CO combines rapidly. It is a rapid combination, okay, which will prevent your pressure to be built in the plasma, okay. So what are the factors that will affect the diffusing capacity? Okay, your respiratory membrane, all the properties of respiratory membrane, and capillary blood volume will also determine the diffusing capacity, okay. Understood? Let's talk about the transport of O2, okay. Beforehand, let's talk about the Dalton's law, okay, Dalton's law and the Boyle's law, okay. Talking about the Dalton's law states that the total pressure exerted by a mixture of gases, okay, P total is equal to your individual pressures of the gases P1, P2, P3 up to Pn, okay, and these pressures are called as a partial pressure of gases, okay. Partial pressure refers to the pressure of a single gas in a mixture, okay, and the Boyle's law states that if the volume of a gas is reduced, the pressure increases. So P is inversely proportional to the volume. It states that P is inversely proportional to the volume, okay. If the volume is reduced, then the pressure will increase, and the vice versa, okay, and provided that the temperature remains constant, which remains constant in this case, okay. So if the chest volume is rising, okay, there is a fall in your alveolar pressure, okay. So how the O2 is transported in the blood, okay. So at the lungs are ventilated constantly, okay. Due to continuous renewal, the PO2 is maintained, okay, even though the composition changes, okay. The PO2 of alveolar air is I've told is 104 mmHg, okay, and the PO2 of venous blood about 64 mmHg. So the O2 diffuses from your alveolar air to the venous air. The venous blood, I'm talking about mainly your pulmonary capillaries, okay, capillaries. This is at the lung site, okay. These are the pressure changes at the lungs. At the site of your tissues, what happens is that arterial blood that is passed to the tissues, okay, the PO2 of your arterial blood is about very high. It is about 97 mmHg, okay. Due to 2% venous admixture, it is reduced from 104 to how much, to 97, okay. And the tissue PO2 of the tissues, it is about PO2 of tissues is about 40 mmHg. Okay, so what happens, the oxygen will diffuse to the tissue due to your pressure gradient, okay. Understood. So how the O2 is transported, modes of transport of O2. Talking about the modes of transport of O2, we have two forms, okay. In combination with hemoglobin, 97% of O2 is transported, and in the dissolved form, like in your plasma, okay, in the plasma form, about 3% is transported, okay. 97% and 3%, okay. So like 3% is carried in dissolved state. It plays an important role because at lungs, when PO2 is high, hemoglobin gets saturated with O2, where at tissues, when PO2 is decreased, okay, hemoglobin gets desaturated, providing a O2 to the tissues, okay. So it is carried by plasma also, and is carried with combination with hemoglobin, okay, in combination with hemoglobin. So how it is combined with hemoglobin and transported, let's check. So hemoglobin combines with O2 reversibly to form oxyhemoglobin called as the HbO2, okay, HbO2. Understood? And when it is released, the oxygen is released, it is called as a reduced hemoglobin or deoxygenated hemoglobin, okay. So oxygen, what happens, it combines with the iron part, okay, okay. One molecule of O2 combines with one iron ion, okay. There are 4 iron ions, okay. So it is designated as Hb4, okay. So it is precise to designate the hemoglobin as Hb4, okay, and this will form Hb4O2. So first step is the Hb4 plus O2 has the 4 iron atoms, okay, and this will form your Hb4O2, okay, or Hb4O2. After each reaction, this will Hb4 plus O2, again it combines with another oxygen, Hb4O4, okay. Then again it combines Hb4 plus O4 plus O2 gives Hb4O6, and this Hb4O6 again combines with O2 to form Hb4O8. Okay, and after each reaction the affinity for combination with O2, this goes on increasing. The affinity increases in each of these methods. Okay, so 1 gram of hemoglobin can combine with 1.34 ml of O2. Okay, and 4 ml of O2. Okay, so at the 100%, this is called as the 100% saturation state, and the 100% saturation state. Okay, so percentage saturation of hemoglobin of hemoglobin is calculated by the formula O2 content of blood per 100 ml by your O2 carrying capacity of blood, into 100. Okay, by this you will get the percentage saturation of hemoglobin, O2 content of blood per 100 ml divided by your O2 carrying capacity of blood into your 100. Okay, this is a percentage saturation. And if you plot the curve of oxygen saturation, okay, then you will get you have a famous curve called as your oxygen dissociation curve, which is your sigmoid shaped, okay. So you get a curve like this. You plot the percentage saturation, okay, and the gaseous pressure of oxygen in mmHg, the pressure of oxygen in mmHg. Okay, so you get a curve like this. This is of sigmoid shaped. Okay, this is of sigmoid shaped. So sigmoid shaped curve is beneficial. This shape is beneficial. Why? Because it will allow greater uptake of O2 at lungs, allows greater uptake at lungs. Okay, and the tissues are supplied according to needs, not more, not less. Okay, and the hemoglobin, which will act as a buffer. Okay, the hemoglobin acts as buffer. Okay, understood? So due to this increase in affinity, the sigmoid shape is due to your increasing affinity after each reaction, okay, which we saw earlier. This one, increasing affinity after each reaction, this will cause the sigmoid shape, okay, which is also called as a cooperative effect in some books. Okay, then there is shifting of the oxygen hemoglobin dissociation curve, okay. Right shift. Let's talk about your right shift. This is a right shift. Okay, this is called as a right shift. So what causes your right shift? So right shift is not advantageous at the lungs. Okay, so this right shift means that there is decreased affinity for hemoglobin for oxygen. Okay, there is decreased affinity of hemoglobin for your oxygen. Okay, so there is a right shift of your oxygen dissociation curve. Okay, and the left shift, there is a left shift also. This is a left shift like this. Okay, this is called as a left shift. Okay, actually I made it wrong. Okay, okay, this is your left side and this is your right side. So okay, no problem in it. Okay, this is your left shift and this will increase your affinity of Hb4O2, and this is your right shift. Okay, right shift. So what are the causes of a right shift and left shift? So left shift and right shift. Okay, so left shift is beneficial for your left shift is not beneficial for your tissues, but right shift is beneficial for your tissues. So factors causing a right shift is your decreased pH of blood. Okay, and factors causing left shift is your increased pH of blood. Okay, so pH differs. Okay, Then increased temperature causes your right shift, increased temperature causes your right shift, decreased temperature causes your left shift. Okay, then increased PCO2 causes your right shift, increased PCO2, and your decreased PCO2 causes your left shift. Okay, and increased 2,3 DPG, diphosphoglycerate, will cause your right shift. Okay, this is important. And your decreased 2,3 DPG, decreased 2,3 DPG will cause your left shift. Okay, and there is left shift also seen. The left shift is also seen in the fetal hemoglobin. Okay, fetal hemoglobin is called as a HbF. Okay, alpha 2 gamma 2. Okay, so it has more affinity. Okay, so it is showing your left shift. Okay, understood. So after this, let's discuss about the Bohrs effect, the shifting of O2 dissociation curve due to the changes in PCO2. This is called as the Bohrs effect. Okay, so Bohrs effect is the shifting. Okay, shifting of O2 dissociation curve. Okay, due to PCO2 changes. Okay, this is called as your Bohrs effect. Okay, this is called as your Bohrs effect. So this left shift will favor your uptake of O2. Okay, and this right shift will favor the dissociation of O2. Okay, understood. Let's talk about another term which is called as P50. Okay, P50. Okay, the point at which the hemoglobin is 50% saturated. Okay, the pressure at which the hemoglobin is 50% saturated, the partial pressure of O2 at which the hemoglobin is 50% saturated is called as a P50 point. Okay, it's called as a P50 point at which the pressure at which the hemoglobin is 50% saturated. Okay, and for a normal adult human being, okay, the P50 value is the 25 mm of Hg. Okay, and if you have decreased P50 levels, okay, if you have decreased P50 values, okay, if you have decreased P50 values, then you can know that there has been left shift occurred. Okay, left shift has occurred. Okay, and if there is increased P50 values, then you can know that right shift has occurred. Okay, understood. So excess CO2, your increased acidity, your increased temperature, your increased level of DPG. Okay, this all will cause your a rise in P50 values. Okay, understood. Okay, then another thing is called as a utilization coefficient of O2. Okay, another thing is called as a utilization coefficient of O2. Another term is there. So let's discuss the utilization coefficient of O2. Okay, utilization coefficient of O2 at rest. Okay, this is denoted by your arterial blood O2 concentration. Arterial blood O2 concentration minus venous blood O2 concentration. Okay, by your arterial blood O2 concentration, okay, into 100. This is the utilization coefficient. So arterial blood O2 is 25 minus venous blood O2 is about 15, by 20 into 100, about 25% in at rest. Okay, about 25. Utilization coefficient of O2 is about 25% at your rest. Okay, and higher level of methemoglobin in blood are called as a methemoglobinemia. Okay, here in methemoglobinemia, okay, there is a disorder called as methemoglobinemia. Okay, in which the heme okay, it binds the iron in ferric state. Okay, in ferric state rather than ferrous state. Okay, ferric state iron. Okay, so patient will show the symptoms of hypoxia. Okay, hypoxia and cyanosis will be seen in the patient. And carboxyhemoglobin is the combination of Hb plus CO. Okay, it forms a carboxyhemoglobin. Okay, and carbon monoxide poisoning is the combination of Hb okay, with the CO gas, okay, because the hemoglobin has 250 times more affinity. It has 250 times more affinity than O2 for carbon monoxide, okay, carbon monoxide, okay. And this is lethal. Carbon monoxide poisoning is lethal because it can cause your hypoxia also. It can cause your hypoxia, okay. And how can you treat the carbon monoxide poisoning? This is called as CO poisoning, okay. How can you treat the CO poisoning? The treatment, okay, the treatment is by your administration of a 100% pure O2, your 100% pure O2, okay. And this 100% pure O2 will just increase the alveolar PO2 by 5 times, okay. And another thing you can do is addition of a small quantity of CO will also be there, is also useful because it can increase the ventilation. So you can treat by either giving 100% pure O2, or you can either or can mix very small quantity of CO2, okay. And this CO2 can increase your ventilation, okay. Understood. Let's move on to your transport of CO2. Let's move on to the transport of CO2 after transport of O2, okay. CO2 is transported from tissues to the atmosphere, okay, because of constant circulation of blood, okay. At this let us take at the tissue level what is happening at tissue level, and let's discuss at what is happening at the lungs level, okay. At the tissue level, what is happening is that cells are constantly forming a CO2, okay, during the metabolism processes, okay. So intracellular PCO2 is always higher than the interstitial fluid PCO2, okay. So this is a cell. If this is a cell, okay, if this is a cell and this is your interstitial fluid, okay, and the cell when the PCO2 will be about 45 mmHg, and the intracellular fluid it will be about 46 mmHg in your cells, and interstitial fluid it will be about 40 to 45, or you can write 45 mmHg, okay. So that CO2 can go into your bloodstream. It can go into your bloodstream. So CO2 will transfer here. At the lungs, the venous blood passing through the pulmonary capillary, okay, has a PCO2 of 45, whereas the alveolar PCO2 is 40, okay. So here you have alveoli and the blood is passing like this, okay. So the venous blood will be in the venous capillaries, okay. So alveoli is 40 mmHg, and here you have 45 mmHg. I am talking about PCO2 values, okay, PCO2 values. So what happens? The CO2 will move to the alveoli, okay. CO2 will move to the alveoli, okay. So this phenomenon occurring at the for the transport of CO2, okay. How the CO2 is transported? The modes of transport are important, okay. So 4 ml of fact is that 4 ml of CO2 is transported per 100 ml of blood, okay, from tissues to lungs, okay. This is important. 4 ml of CO2 is transported per 100 ml of blood from tissues to lungs, okay. So what are the modes of transport? First is the dissolved state in plasma. Dissolved in plasma we have 75%, okay. Dissolved in plasma we have 75%, okay. Then we have in bicarbonate form, HCO3 minus form, we have about 70%, and in your carbamino compound form, like it reacts it directly with the amino group in carbamino compound. Carbamino compound form about 23%, okay. Theoretically it can carry 30%, but normally it is carrying 23%, because the reaction of CO2 with amino group of protein is like slower than the reaction of CO2 with water in your RBCs, okay. So this is how it is transported. Understood? So dissolved in plasma means in venous blood the PCO2 is 45. Amount of CO2 in dissolved state is about 2.7 ml per 100 ml, okay. So about 0.2 3 ml of CO2 is carried per 100 ml in dissolved state, about 0.75%. You can calculate from this 4 ml, 75% of this 4 ml. Okay, and in after entering your blood, CO2 combines with the water formed H2CO3. Okay, and like we have a phenomenon here, like let's say you have the capillary. Okay, here you have the capillary. Okay, the capillary, and here you have an RBC. Okay, here you have an RBC. Let's discuss the mechanism here, okay, so that we can get some more spaces and can explain the mechanism in good detail. Okay, here is our capillary. And let's take here as a your RBC. Okay, here is a RBC. And here is the interstitial fluid. Okay, and here is a cell. Let's say here is a cell. So the cell will give your CO2. Okay, CO2. So how much percent of CO2 is transported in the in combination with your plasma? Okay, about 7% only. Okay, here I wrote some mistake. This is 7%. Okay, and HCO3 in the HCO3 form it is 70%. Okay, so 70% of CO2 goes here. 70% of CO2 goes here. Okay, CO2 combines with the H2O, forming the H2CO3. Forming the H2CO3, which dissociates into HCO3 minus plus H plus. Okay, and this HCO3 minus goes out. This HCO3 minus is going out to the capillary, out of the RBC, and due to this going out of the HCO3 minus, another one is coming in, which is called as your Cl. Okay, which is coming as your Cl, and this Cl, this phenomenon is called as your chloride shift. Okay, this is to maintain the electrical neutrality. Chloride shift, or it is called as your Hamburger phenomenon. Okay, so this is basically the chloride shift that is occurring here. Okay, the chloride shift that is occurring here. Understood? Afterwards, if you understood what is your chloride shift, okay, if you understood what is a chloride shift and how it is occurring, okay, this is transported in the form of HCO3 minus. Okay, this H plus combines with the H hemoglobin. Okay, this H plus combines with the hemoglobin and forms the HHB. Okay, forms the HHB. Understood? And on combination of this CO2 which hemoglobin, okay, this forms HB plus CO2. Okay, it also goes in your dissolved state. Okay, it also goes in your dissolved state in plasma. Okay, dissolved state in plasma, as well as in bicarbonate form. It goes in also in your bicarbonate form. And also what happens, another thing is that the CO2 directly reacts with your NH2, RNH2 plus CO2. Okay, it can form your RNHCOOH. Okay, RNHCOOH, which is a carbamino compound, and about 23% is traveling by this method, the third method. Okay, so you got to know about the chloride shift and how that are occurring. Okay, understood? So after this, there is a question asked that why the venous RBCs are more fragile. Why the venous RBCs are more fragile than the arterial RBC. Okay, because of the chloride shift. Because of the chloride shift. Okay, the ratio which is called as your HCO3 minus inside by HCO3 minus outside. Okay, this ratio which is equal to your chlorine inside and your chlorine outside, this ratio is higher. This ratio is higher in venous blood than in arterial blood. Okay, this ratio is more in a venous blood than in arterial blood, as a result of which the osmotic pressure of RBC is become higher than plasma, leading to a osmotic absorption of fluid into RBC. Okay, the RBCs get filled with fluid. Okay, so the venous RBC, due to this higher ratio, okay, this can create an osmotic effect which will cause the fluid to enter the RBC. The fluids can enter the RBC, the water can enter the RBC. Okay, and this can cause your fragility. Okay, so increased ratio causes your fragility. Understood? Okay, another one effect is there, that is called as Haldane effect. So what is Haldane effect? It is the effect, it is a deoxyhemoglobin, the reduced hemoglobin. Okay, the deoxyhemoglobin, okay, combines with more CO2. Okay, the deoxyhemoglobin combines with more CO2 as compared to your oxygen. Okay, deoxyhemoglobin has more affinity to the carbon dioxide as compared to your oxygen, because due to this effect of the importance, so due to this effect only, the quantity of CO2 to be carried to tissues, and carried from tissues to lungs, this doubles. Okay, then I have a term called as the respiratory exchange ratio. What is respiratory exchange ratio? Is that it is the R is equal to rate of CO2 output by rate of O2 uptake. Okay, R is equal to rate of CO2 output by your rate of O2 uptake. Okay, when the carbohydrates are used for metabolism, the R is 1. Okay, this for carbs, the respiratory ratio is about 1. Okay, when fat is utilized, the respiratory ratio is about 0.7. Okay, and for the balanced diet, the R is about 0.825. Sorry, it is about 0.825. Okay, for carb, fat, and your balanced diet. Understood? Now let's come to our important topic, that is your regulation of respiration, which is very, very important. Okay, we have the new nervous mechanism of regulation. Okay, control of breathing is important. Okay, this can come as your short note or your long question and all. This can come as a long question basically. Okay, and each part is a short note. Okay, the reflexes are there: pre-Borginger complex, the apnoistic center, the Hering-Breuer reflex. Okay, and how the chemical control is being done. Okay, and what are the abnormal breathing patterns? Okay, what are the sneeze reflex and all, asphyxia and ventilation patterns and all. Okay, so this should be taught. Okay, so let's learn about the regulation of respiration. Okay, talking about the regulation of respiration, so the mechanisms. Okay, there are two regulatory mechanisms. One is called as a nervous control, it's called as a nervous regulation, and another one called as a chemical regulation. Okay, chemical regulation. Nervous mechanism is done by the nuclei. Okay, this nuclei from the group of neurons from your medulla and pons. Okay, this form respiratory centers. Okay, there are four major respiratory centers: your DRG. Okay, dorsal in two groups. Okay, your DRG and VRG, or VRG and DRG. Okay, and these are located in medulla. Okay, these are located in medulla, and then again you have two in the pons, that is apnoistic center and your pneumotaxic center. Okay, which is located in your pons. Okay, understood? And the chemical regulation also, it regulates ventilation in response to your changes in arterial with response to your changes in your PO2 and your PCO2. Okay, and your H plus concentrations. Okay, and your H plus concentration. So let's learn about the nervous regulation. So as you know, heart can generate its own rhythm. Okay, so but in respiratory muscles, it requires electrical stimulation by somatic nerves to initiate your contraction. Okay, so dorsal respiratory group and ventral respiratory group are two groups of neurons. Okay, DRG and VRG. Okay, so what are the functions of your medullary respiratory center? Okay, DRG and VRG. Okay, so first of all, let's talk about your DRG, dorsal respiratory group, DRG. So DRG is located in location is the nucleus of tractus solitarius, solitarius, and some neurons in adjacent areas. Okay, and some like the adjacent areas. Okay, this emit repeated bursts of inspiratory action potentials. Emit inspiratory action potentials. Okay, these emit inspiratory action potentials. Okay, and the neurons receive the sensory output via different parts. Okay, the signal are transmitted to your inspiratory muscles. Okay, and this inspiratory action potentials, these are received by your ninth nerve and these are received by your 10th nerve. Okay, ninth nerve and your 10th nerve, and these signals are transmitted to your inspiratory muscles, your diaphragm and your external intercostal muscles. Okay, then talking about what is a ramp signal. Okay, ramp signal is a signal from respiratory neurons, is not instantaneous, but it is a ramp signal. Okay, weak in beginning and steadily increases in a ramp manner. Okay, which increases the lung volume during respiration rather than in respiratory gasps. Okay, it's not abrupt distension will not occur. Okay, it will steady increase in lung volume. Okay, so the signals are called as a ramp signals, due to which there will be not instantaneous, but it is the signals are weak. Okay, weak, and it steadily increase steadily increase, like you have seen a ramp like this increasing like this, the height will increase like this. So ramp signals. Okay, these ramp signals will cause your steady contraction. Okay, this will cause your steady contraction, okay, of the inspiratory muscles. Okay, of the inspiratory muscles. Understood? Okay, so this ramp like signals, okay, they start from 0, okay, and then increase up to 2 seconds. This is an increase steadily up to 2 seconds. Okay, up to 2 seconds. Then what happens that they abruptly cease. Okay, they abruptly cease here up to 3 seconds. Okay, for the next 3 seconds, so 2 and up to 5 seconds, so they cease for the next 3 seconds. Okay, which will turn off the excitation of diaphragm and EICM. Okay, so they relax. Okay, and expiration will cause. Okay, this ceasing, this abrupt cease will cause your expiration. Okay, expiration. Again there is another ramp signal. Okay, it again rises up to 7 seconds, and it abruptly ceases. Okay, causing your that expiration. Then again it rises. Okay, so these are the ramp cycles. Okay, causing a tidal respirations. Okay, so these are the DRG. And talking about VRG, ventral respiratory group, this is located in your location is your nucleus ambiguous, and your nucleus retroambiguous. Another nucleus is that which is called as nucleus retroambiguous. Okay, and in tidal respiration, in normal inactive, this remain inactive in tidal respiration. Okay, but these are activated in forced ones. Okay, these are inactivated in the tidal respiration. Okay, and the normal breathing is to repeated inspiratory signals from your DRG neurons. Okay, but VRG neurons, they play a role in when respiratory drive increases and the respiratory signals spill over into the VRG from DRG. Okay, when there is a spillover of signals, spillover of signals. This spillover of signals, it stimulates your VRG. Okay, this VRGs are stimulated. Okay, and the VRG work in your forced expiration, work in forced expiration. Okay, let's talk about your apneustic center. So apneustic center is located in the lower part of pons. In the lower pons it is located. Okay, it sends signal to the DRG by neurons that prevent the switch off of your inspiratory ramp signal, which will lead to your prolonged inspiration, and this is called as apneusis. So apneustic center is derived from the name apneusis. What is apneusis? It is your prolonged inspiration. So what it does is that it stimulates, it sends signal to the DRG, which prevent switch off of inspiratory ramp signals. Okay, prevent switch off of inspiratory ramp signals. So let's say this is a ramp signal, okay, and this is another ramp signal, and so on. Okay, so this is the abrupt cease from 2 seconds to 5 seconds. Okay, so it what it will do, the DRG, it will cause this signal, okay, to be prolonged. Okay, this will cause this signal to be prolonged. Okay, this will cause the prolongation of your inspiratory signals. Okay, prolongation of your inspiratory signals. So this is the effect of your apneustic center. Okay, understood? And it works in close approximation of your with your pneumotaxic center also. Okay, now let's talk about your pneumotaxic center. What does it do? Okay, let's talk about your pneumotaxic center. Talking about the pneumotaxic center, which is located bilaterally in the nucleus parabrachialis of upper pons. Location is your nucleus parabrachialis, okay, which is located in the upper pons region. Okay, primary center is to control the switch off point of inspiratory ramp. Okay, and thus controls the duration of inspiration. So pneumotaxic center controls the duration of inspiration. This is an important fact, duration of inspiration. What does it does? It controls switch off points of your inspiratory ramp. Control switch off point of your inspiratory ramp signals. Okay, thus control the duration of inspiration. Okay, when the pneumotaxic signal is strong, okay, the rate of respiration increases to 30 to 40 breaths per minute. So the normal is 12 to 15. Okay, when there is strong pneumotaxic signal, the respiration, the rate will increase up to 30 to 40 beats per minute. Okay, breaths per minute. Okay, due to rapid switching of your ramp signals duration. Okay, so what is the effect of your this center, pneumotaxic center? It will just finish off your it will just if there is strong, okay, there is strong pneumotaxic stimulation, it will switch off your inspiration at short periods. Okay, short periods. And weak pneumotaxic signal may reduce the rate only to a few breaths per minute. Okay, so rhythm of respiration. Okay, rhythm of the respiration. Okay, the center controlling rhythm of respiration is DRG. Okay, it controls the rhythm of respiration. The rate and duration of respiration is controlled by apneustic center as well as your pneumotaxic center. Okay, these both centers controlling the rate and duration of your respiration. Okay, another thing is called as your pre-Böttinger complex. Okay, the pre-Böttinger complex. Let's talk about the pre-Böttinger complex. So what is the role of a pre-Böttinger complex? Is that it is located bilaterally between the nucleus ambiguous, okay, and the lateral reticular nucleus, Okay, it has few pacemaker cells. Okay, pacemaker cells that generate the rhythm of respiration. Okay, this pacemaker cells, they fire rhythmically. Okay, they fire and activate your phrenic motor neurons. In spinal cord. Okay, and this will cause your inspiratory ramp activity. Okay, what is the role of higher controls? Is the respiration goes on absolutely unconsciously, and higher centers can only temporarily cause your breath holding or temporary hyperventilation. Okay, so higher centers, generally the higher centers of respiration, higher centers are generally lying in your reticular activating system, and your limbic system. And this pre-Bolginger complex also works in close association with DRG and your VRG. Okay, DRG and your VRG. Understood? Then we'll go to another thing which is called as your Herring-Brewer reflex. Okay, we'll discuss a thing which is called as your Herring-Brewer reflex. Okay, this is the inhibition of your inspiration on excess inflation of lungs. It is called as Herring-Brewer reflex. Okay, if the lung is excessively inflated, okay, and the stretch receptors are stimulated, okay, so the impulses travel via your vagus nerve to your pontine and medullary respiratory centers. Okay, and this will inhibit your respiration. Okay, what is importance? Okay, it is only initiated, Herring-Brewer reflex, it is initiated when your tidal volume becomes more than 1.5 liter. Okay, which can have a extensive distension of lungs, may cause lung damage. Okay, it prevents lung damage. Okay, and other importance is to minimize the work of breathing. Okay, so as to so minimize the work of breathing, so that there is minimal expenditure of energy. Okay, this is the importance of a Herring-Brewer reflex. Okay, let's talk about a chemical control of respiration. Okay, talking about a chemical control of respiration. Okay, so we talked about your nervous control of respiration here above. Okay, we talked about your nervous control of respiration. Let's talk about your chemical control of respiration. Okay, what factors are controlling the respiration? The PCO2, your PO2, and your pH. Okay, these are regulating a respiration. Okay, what are central chemoreceptors? Okay, these are chemoreceptors which are neurons which are present just beneath the ventral surface of medulla. Okay, so we have medullary chemoreceptors. Or your central chemoreceptors. Okay, and we have also peripheral chemoreceptors. We have also peripheral chemoreceptors. Okay, central chemoreceptors are present in the ventral part of your medulla. Okay, this is present on the ventral surface of medulla. Okay, and this medullary chemoreceptor, these are sensitive to your H+ concentration of your CSF. Okay, the medullary chemoreceptors. Okay, so what happens is that when there is increased concentration of blood, Okay, what is the mechanism of the medullary chemoreceptors? So the mechanism of medullary chemoreceptors. Okay, when there is increased PCO2 of the blood, okay, the CO2 concentration in CSF increases. Okay, because there is no blood CSF barrier for CO2. Okay, in the CSF also the CO2 combines with water. In CSF, what happens? The CO2 combines with water to form H2CO3, and H2CO3 this breaks down into H plus and HCO3 minus. So H plus concentration is increased. Okay, H plus concentration is increased. Due to increase in H plus concentration, okay, this central chemoreceptors are stimulated. Okay, these are central chemoreceptors are stimulated, leading to increase in inspiratory rate. They lead to increase in your respiratory rate, okay, and depth. Okay, about due to 85% of resting respiratory drive is due to the stimulatory effect of CO2 on your central receptor, on your central chemoreceptors. Okay, about 85% of effect. Okay, understood? Okay, so increased PCO2 is more effective in stimulating the central chemoreceptors than increased PCO2 in interstitial fluid of the brain, because actual stimulation is your H plus ion. Okay, in CSF there are no buffers to buffer out the H plus ions. Okay, in CSF we don't have any buffers, no buffers are there. Okay, so the H plus concentration is just absolute here, absolute in CSF. Okay, absolute in CSF due to no buffers. Okay, that's why. Okay, and where are the peripheral chemoreceptors are there, and what are the stimuli for them? Let's look at this. Okay, what are the peripheral chemoreceptors and what are their stimuli? Okay, so peripheral chemoreceptors are situated in your carotid and aortic bodies. Okay, and carotid chemoreceptors are most important peripheral chemoreceptors. Okay, these are your situated over here, carotid and your aortic bodies, and your aortic bodies. Okay, so if this is the arch of aorta, okay, and here you have the common carotid artery and your subclavian artery, you know all this. Okay, right common carotid and your left common carotid artery. Okay, then here is the arch of aorta. Okay, so where you have this aortic bodies present. These are the aortic bodies. Okay, and here are some carotid bodies present. Here are your carotid bodies, and these carotid bodies are more important than your aortic bodies. Okay, these are more important, like it is the most important peripheral chemoreceptor. Okay, so carotid body, talking about your carotid body. So carotid body, it has two types of cells. Okay, it has two types of cells. One is the type 1 cell in the carotid body, and is a type 2 cell. Type 1 cell has are called as the glomus cells, having voltage gated channels on the membrane. These have voltage gated channels on membrane. Okay, so type 1 cells mainly respond to hypoxia. These are sensitive to hypoxia. They're sensitive to your hypoxia. Okay, they're sensitive to your hypoxia, and they release dopamine. Okay, they release dopamine, and this dopamine acts on your cranial nerve 9th. This dopamine acts on your cranial nerve 9th. Okay, triggering your action potential, and in the carotid sinus nerve. Okay, action potential in your carotid sinus nerve, and this action potential will stimulate your respiratory center. And this respiratory center will increase your ventilation. Okay, and this type 2 cell, they are the supporting cells. They support this type 1 cells. Okay, so did you understand the mechanism, how they are working? Okay, and this aortic bodies also have similar cells to carotid bodies. Okay, these are like innervated by the vagal efferents. Okay, this basic mechanism is remaining the same. Okay, the firing of action potential. This aortic bodies also act by nearly same mechanism. Okay, understood? So for peripheral chemoreceptors, your lack of O2, okay, your O2 is the indicator for your peripheral chemoreceptor. This is the indicator for peripheral chemoreceptor, okay. So this peripheral chemoreceptor is rich blood supply unless the PO2 falls, unless it falls below 60 mmHg, okay, it doesn't stimulate your chemoreceptors, okay, as the chemoreceptors are also richly supplied with your oxygen, okay. So this is not there, okay. Another thing is your braking effect of CO2. Anything which is called as your braking effect of CO2. So what is braking effect of CO2? If there is decrease in PO2 of arterial blood or decreased pH, okay, it stimulates ventilation, okay, and this increased ventilation will cause washing out of CO2. This lead to decreased PCO2, okay, and this decreased PCO2 this will inhibit the respiration via, this will inhibit the central chemoreceptors. This will the central chemoreceptors will inhibit the respiration, okay. So if there is decreased PO2, the respiration is inhibited, okay. If there is decreased pH and there is washing out of your CO2, this is called as a braking action of CO2, okay. So CO2 has a direct effect, you can see on medullary chemoreceptor. If PCO2 is increased, then your H plus increase, and H plus will stimulate and increase the respiratory rate and the depth, okay. So you can say that the CO2 it is a main regulator of your respiration. This is the main regulator, okay, it has a direct effect on your respiratory center, okay. And the concentration also remains constant, okay. Concentration also remains constant as CO2 has no blood brain barrier. The concentration, okay, in blood it increases, okay, increases. It has also a strong braking effect, okay. And the PO2 and pH also don't have strong braking effects as compared to your CO2 has. So CO2 is like acting as a regulator of respiration and is a significant part, okay. Let's talk about some abnormal breathing patterns now. Abnormal breathing patterns, okay. Talking about abnormal breathing patterns, we have first Chinese Stokes breathing, okay. Chinese Stokes breathing or Chinese Stokes breathing, whatever you may pronounce, okay. This is a periodic breathing where there are alternate periods of respiratory activity and apnea occurring at regular intervals, okay. That's a waxing and waning of your tidal volume, okay. Like there is a respiratory activity, then apnea is there, okay, then again respiratory activity, then apnea is there again, and apnea is there. So it is periodic, okay, but interrupted by these periods of apnea. So these are the periods of apnea. There is no breathing, okay. So there is waxing and waning of tidal volume. There is waxing and waning of your tidal volume, okay. So it occurs, Chinese Stokes respiration, it occurs when there is increased circulation time from lungs to brain, as if like in your chronic heart failure, okay. It occurs in your chronic heart failure, okay, or your brain damage. It is also seen in your infants, because respiratory centers yet not developed, okay. So you can get a short note on your Chinese Stokes respiration, you can write, okay. You can draw the diagram, okay. Then another thing is your Biot's breathing, okay. So what is your Biot's breathing is that there's a type of periodic breathing, okay. So there's alternate periods of respiratory activity, and apnea occurs at irregular intervals, okay. This is the breathing. Then apnea is a long apnea. Then breathing short apnea, breathing short apnea, breathing another long apnea. Okay, so there is apnea, periods of apnea, but irregularly. Okay, so there are irregular periods of apnea. Okay, apnea occurring at irregular intervals. Okay, apnea at irregular intervals. In your Chinese Stroke's respiration, in a Chinese Stroke's respiration, it is occurring at regular intervals. Okay, but here it is apnea occurring at irregular intervals, which is called as Byers breathing. Okay, it is never be physiological. It is observed with the brain damage. Okay, it is observed with the brain damage. Okay, in the brain damage it occurs. Okay, brain damage. Understood? Byers breathing occurs in your brain damage. Then we'll talk about another type of breathing, which is called as your Kussmaul's breathing. Okay, Kussmaul's breathing. So you know Kussmaul's breathing, it occurs in your diabetic ketoacidosis, in DKA, your diabetic ketoacidosis it occurs. Okay, it is a deep and rapid breathing. Okay, it is a deep and rapid breathing, deep rapid breathing. Okay, deep rapid breathing. Okay, it is observed in your diabetic ketoacidosis. Okay, and diabetic ketoacidosis causes metabolic acidosis. Okay, metabolic acidosis. And this metabolic acidosis will cause this deep rapid breathing called as your Kussmaul's breathing. Okay, and apnea is a stoppage of respiration. As I told earlier, apnea is a stoppage of respiration. Okay, it's commonly seen physiologically during deglutition. You can just try swallowing and try respirating, you can't. Okay, and during sleep apnea is sometimes observed, and after hyperventilation there are some minutes of your there is apnea. Okay, what is sleep apnea? Sleep apnea is the periods of apnea during the sleep. Okay, observed mainly in REM sleep, because there is the loss of tone. Okay, so people with sleep apnea may complain of your fatigue, your daytime sleepiness, your headache, etc. Okay, a syndrome is there which is called as your sudden respiratory death syndrome. Okay, SIDS, sudden respiratory sudden not respiratory sudden infant death syndrome, SIDS. This is a sudden infant death syndrome. Okay, sudden infant death syndrome. It's a common cause of infant death in the first year of life. Okay, and is a form of exaggerated sleep apnea. It is a form of exaggerated sleep apnea. Okay, exaggerated sleep apnea has been occurred, and the person never recovers from that. The death occurs. Okay, in many SIDS cases, often the causes are unknown. Okay, because in many cases the infant forget to breathe because of immature respiratory control mechanism. Okay, there is in brainstem and chemoreceptors. Okay, some abnormal lung development, or if the infant forgets to breathe. Okay, and the aspiration of stomach juice also causes SIDS. So one of the causes is that the stomach juice, their aspiration occurs of the stomach juice, and it contains your Helicobacter pylori. Okay, Helicobacter pylori. This Helicobacter pylori will release your ammonia, and this, if it goes to the lungs, then it will lead to SIDS. Okay, so it is the risk factor is your smoking mothers. Okay, the mothers who continue smoking during pregnancy. Okay, smoking mothers. Okay, then talking about what is a cuff reflex. Entry of any foreign material initiates this reflex. Okay, even small amount of irritant stimuli initiates your cuff reflex. Okay, initiates the cuff reflex. Okay, so when the irritant material goes to enters the respiratory tract. Okay, it passes via the vagus nerve, to the medulla. Okay, medulla, and from the medulla there first occurs a rapid inspiration. Inspiration of 2.5 liters of air. Okay, then epiglottis closes. Okay, and your vocal cords are shut. Okay, then the abdominal muscles contract forcefully, and this causes the pressure inside the lung, the pressure of lungs. Okay, this rises to about 100 mmHg. Okay, and after this the vocal cords and the epiglottis, the VC and epiglottis, okay, they open, and under high pressure the lungs, okay, it explodes outward. Okay. Explodes outward. Okay, this is called as a cuff reflex. This is called as a cuff reflex. Okay, understood. After this there is a sneeze reflex also. Let's talk about the sneeze reflex. So what is the sneeze reflex? It is also a protective reflex. Okay, if there is some irritation in the nasal passage, okay, then the signals pass through your trigeminal nerve, your fifth nerve, trigeminal nerve, okay, to the medulla, and then the same events as cuff reflex occur. Same events. Okay, what happened? It is gone. Okay, no problem. Here, and your respiratory. Yes. Okay, so the same events as your cuff reflex occur. Okay, just that the uvula is depressed in this case. Okay, depressed in this case. Understood? So apnea, you know about the temporary stoppage of the respiration. Hyperventilation is the increased rate and the depth of your breathing. Okay, hypocapnia is your decreased PCO2. Okay, it can lead to vasoconstriction, your ischemia, your respiratory alkalosis and all. Okay, and hypoventilation is a decreased rate of depth of breathing, which can cause your hypercapnia, which can cause respiratory depression and respiratory alkalosis. Okay, dyspnea is your difficult breathing. Okay, difficult breathing. Okay, and discomfort develops where the ventilation increased fourfold. Okay, which is called as a dyspnea point. Okay, dyspnea point and air hunger. These two things are there. Okay, and eupnea is the normal quiet breathing. It is called as a eupnea. This is a normal breathing. Okay, another thing is called as asphyxia. That means your occlusion of airways, airway occlusion. Okay, so it combines your hypoxia, as well as a hypercapnia. Okay, it can be generalized or local. It can be general asphyxia or it can be local asphyxia. Okay, it can be general asphyxia or it can be local asphyxia. Okay, local asphyxia is due to your obstruction or ligation of a blood vessel. Okay, is due to your blood vessel obstruction. But general asphyxia, local asphyxia is due to your blood vessel obstruction, but your general asphyxia can be acute or chronic. Okay, acute or chronic, like your lung diseases, and acute asphyxia is seen in strangulation. Okay, in a strangulation where there is acute tracheal obstruction and paralysis of your diaphragm, like in polio. Okay, so there are general asphyxia can be chronic. Okay, chronic as in your cor pulmonale. Cor pulmonale means your right ventricular failure due to lung disease. Your right ventricle is failure. Okay, right ventricle failure due to lung disease. Okay, and your acute as in the cases of strangulation. Okay, so there are 3 stages of acute asphyxia. Acute asphyxia has about 3 stages. Okay, what are the 3 stages of acute asphyxia? It has stage 1, okay, and the stage 2 and the stage 3. Okay, so stage 1 is about 1 minute of duration, stage 2 about 1 to 2 minutes, okay, 1 to 2 minutes, and stage 3 about 2 to 3 minutes of duration. Okay, due to increased PCO2, the respiratory center is stimulated, okay, in stage 1. Okay, due to increased PCO2, the PCO2 is increased. In your asphyxia there is hypoxia and hypercapnia. Okay, due to increased PCO2, your respiratory center is stimulated, okay, which will increase the depth, okay, and rate of respiration. Okay, this will cause a dyspnea. Okay, stage 1, in stage 1. And in stage 2, what happens, your convulsions will be seen. Okay, in convulsions, coma like states will be seen. Okay, there will be the rise of BP due to vasoconstriction. Okay, there will be pupil will be constricted, pupillary constriction. Okay, pupillary constriction. And the reflexes, there will be hyperreflexia. Okay, and excess this excess CO2 stimulating center. Okay, and it is called as a stage of a central excitation. This is also called as a stage 2, is also called as a stage of central excitation. Okay, and stage 3 convulsions is cease. Okay, there will be slow respiration in this stage, slow respiration. Okay, there will be fall of BP, pupillary dilation, pupil dilated, pupillary dilation. Okay, and O2 lack, as due to the O2 is lacked. Okay, there will be inhibition of vital centers, inhibition of all the vital centers of the body, and this will lead to death. Okay, so this is called asphyxial death. So there is another disorder which is called as hypoxia. Okay, hypoxia may be of 4 types. Okay, this is inadequate O2 supply. Okay, this may be caused due to decreased PO2, okay, which is called as a arterial hypoxia. So this is the first type. Okay, and this may be due to decreased O2 carrying capacity of blood, which is called as a anemic hypoxia. Okay, it may be also caused to decreased rate of blood flow, okay, to tissue, which is called as stagnant hypoxia. And it may be caused due to inability of tissues to utilize the O2, which is called as your 4th histotoxic hypoxia. Okay, understood? Arterial, anemic, stagnant, and your histotoxic hypoxia. So arterial hypoxia, this may be occurring due to your high altitudes. Okay, high altitude or your hypoventilation. Okay, or due to your BQ ratio imbalances, your anatomic shunt mechanism. Okay, many causes. Anemic hypoxia is due to your decreased HB content of blood, okay, due to decreased hemoglobin or altered hemoglobin like HB methemoglobin or your HbCO, okay, carboxy hemoglobin. Stagnant hypoxia is due to abnormalities in your vessels, like your vessels are blocked. Okay, your vessels are blocked by many vessels blocking disorders like atherosclerosis or thrombosis. And histotoxic hypoxia is due to some poisons, like metabolic poisons, like your cyanide. Okay, the cyanide. Okay. And giving O2 oxygen therapy is helpful in acute and chronic hypoxia. Okay, in hypoxic hypoxia, okay, O2 therapy is useful, but in stagnant hypoxia, this giving O2 might not help. Okay, because blood flow to tissues is decreased. Okay, it will not be beneficial. Okay, and in hypercapnia, where hypoxia is associated with hypercapnia, okay, raised PCO2 level. Okay, If O2 therapy is given, it will remove the main stimulus for peripheral chemoreceptors, okay, and this will lead to depression of your respiratory center, okay. So in patients, especially with respiratory failure, it can be dangerous to give 100% O2 therapy, okay. So in respiratory failure patients, it can be dangerous to give 100% O2 therapy, okay. Then what are the facts that what will be you will see, okay, in the person suffering from hypoxia. So in a person suffering from hypoxia, the person will present with some disorders like your tachycardia, because the heart rate will be more, the patient present with the tachycardia, okay, and the rate and depth of respiration will be found to be increased, okay. There will be dyspnea and cyanosis, fatigue and all, okay, fatigue and all. Understood? So hypoxia is very dangerous, okay. Hypoxia is very dangerous. This high altitudes also are sometimes causing the hypoxia, okay, and these high altitudes are causing a hypoxia, okay. And about your significance of hyperbaric oxygen therapy. Oxygen therapy is the administration of your 100% oxygen at increased pressure, okay. Sometimes it is called as a hyperbaric oxygen therapy. So hyperbaric oxygen therapy, okay. Oxygen is administered at your 2 to 3 atm pressure, 2 to 3 atm pressure, and some oxidizing free radicals will be formed, which will be useful in treatment of your chronic wounds, your ulcers, and CO poisoning, okay. It is and leprosy type of disorders, okay. And what are the side effects? The side effect will be that it can cause your convulsions, your muscle twitch, okay. It can cause irritability, it can cause blurred vision, okay. And this hyperbaric oxygen therapy, it is mainly involved with the generation of your oxidizing free radicals. These are oxidizing free radicals, okay, which are curing these conditions, okay. Understood? And another thing is, what are the lung disorders that can cause hypoxia, okay. So lung disorders like your emphysema, your pulmonary edema, your asthma, and your pulmonary fibrosis, okay. These are the disorders which can cause your hypoxia. There is a chapter in the Guyton which is called as acclimatization, okay. So let's read the chapter acclimatization now. Acclimatization refers to the changes in the body tissues, okay, in response to long-term exposure to hypoxia, okay. When a person who is living at the sea level, okay, he goes to the high altitude, okay. So the person will gradually be acclimatized, okay. The person will be acclimatized to low PO2, which is in the high altitudes, okay. The PO2 in high altitudes is very low, okay. What are the changes, okay? What are the changes which are occurring during the acclimatization, okay? This is important. What are the changes during the acclimatization? So there is what the changes. This can be asked as a short note, or acclimatization as a short note, okay. What are the changes? So the person will suffer from the changes like your increase in pulmonary ventilation, okay. For high altitude, the pulmonary ventilation is increased due to hypoxic stimulation, okay, peripheral chemoreceptor due to low O2. Okay, it stimulates your peripheral chemoreceptors. Okay, this peripheral chemoreceptors will cause your increased pulmonary ventilation. Okay. Then there is the ventilation will be increased to 5 times more, 5 times of normal, and this increase is due to the loss of braking effect. Okay, loss of braking effect of O2 of CO2 due to renal correction of alkalosis. Okay, this is due to loss of braking effect of your due to loss of braking effect of your CO2. Okay, due to renal correction of alkalosis. Okay, and in high altitudes your kidney secrete your hypoxia is the stimulus for secretion of your erythropoietin hormone from your kidneys. Okay, which increase the rate of your RBC production. Okay, the hematocrit increases, or a PCV which you say, increases from your 40 to 45%, okay, to about 60% in full acclimatization. Okay, and the concentration of hemoglobin rises, okay, to about 20 gram per 100 ml. Okay, there is an increase in blood volume also, 20% to 30% increase in blood volume. Okay, then there is increase in circulating hemoglobin by 50%. Okay, increase in hemoglobin by 50%. Okay, understood. And another thing is that the increased pulmonary capillary blood volume, it increases the capillaries, the surface area of capillary increase, which increase the diffusing capacity. Okay, increase in surface area of capillaries which increase your diffusing capacity, of your lungs. Understood. And this hypoxia, the stimulus, okay, this also stimulates your vasomotor center. Okay, this stimulates your vasomotor center, which causes increase in heart rate and increased force of contraction of heart, and this all will lead to 30% increase in your cardiac output also. Okay, 30% increase in your cardiac output also. Understood. And hypoxia also, so you can note many changes are there occurring. So hypoxia can raise your 2-3 dpg levels, okay, which can cause your O2 dissociation curve to right shift, okay, and increase in P50 levels. Okay, and there is increase in number of capillaries. Okay, and angiogenesis is stimulated, the blood vessels are formed more and more, so there is angiogenesis also. Okay, and your mitochondria and oxidative systems are more plentiful also. Okay, so here this is about acclimatization. We have a disorder which is called as acute mountain sickness. Like if the person is at high altitude about 9,000 to 10,000 feet above sea level, okay, then it suffers from acute mountain sickness. Okay, there may be cerebral pulmonary edema also. Okay, symptoms, what are the symptoms? So fatigue, nausea, okay, this is all, fatigue and nausea, okay, vomiting, then loss of appetite, dyspnea, okay, headache, This is all. Okay, then we have after acute mountain sickness we have another sickness, we have another sickness which is called as chronic mountain sickness. Chronic mountain sickness, which is called as Monge disease. Okay, okay. This occurs in a long term residence of high altitude. Okay, like people living in your hills for years. Okay, due to polycythemia, your viscosity of blood increases. Okay, which causes cyanosis, fatigue, and exercise intolerance. Your pulmonary hypertension. Okay, your pulmonary edema, and this pulmonary edema, this may lead to your right side heart failure. Okay, and to treat this pulmonary edema, you can give the drug acetozolamide. Okay, this is a diuretic drug. Okay, and then other things to treat this disorder, you can give you steroids. Okay, you can give your calcium channel blockers, O2 therapy and all. Okay, let's discuss about another disorder which is called as cyanosis. So cyanosis is the bluish discoloration of skin, of your skin, as well as your mucous membrane also, due to increased amount of your reduced hemoglobin in capillaries. Okay, more than, if there is more about more than equal to 5 gram of reduced hemoglobin, okay, then the cyanosis occur. Okay, and the blue color of skin and the mucous membrane is developed. Okay, so cyanosis may be of different types also. Okay, cyanosis may be of central type. Okay, cyanosis may be central, or peripheral cyanosis. So central cyanosis means when there is central the lungs are diseased. Okay, here the lungs are diseased. Okay, so there is decreased oxygenation of your hemoglobin. Okay, and peripheral cyanosis means where there is a defect in your O2 transport from your lungs. So O2 is not being transferred from the lungs to periphery. Okay, so here the peripheral cyanosis has occurred. Okay, and if both is present, like in chronic cor pulmonale, this is called as the mixed cyanosis. Okay, so cyanosis is obvious in person with fair complexion. Okay, and there is sluggish blood flow. The skin can show cyanosis. Okay, it is more marked in areas such as your lips, chin, your lips, cheeks, earlobes. Okay, there's all fingertips. Okay, mainly it marks on fingertips you can see. Okay, lips and cheeks also, lips and your earlobes. Okay, these all are marked. Okay, understood. And infants in cold weather, it is physiological cyanosis is observed. Okay, and these are present. Another disorder which you have to discuss, that is your effect of high partial pressure. What happened? Another disorder which is your what are the effects of high partial pressure on gases of body. Okay, when a person is exposed to high partial pressure of gases, like the person goes below sea level, like in divers. Okay, in divers, if you go just below sea level, if you go just 10 meter depth, okay, there is an increase in pressure. Okay, increase in pressure by about 1 atm. Okay, 1 atm is very much. Okay, so what are the hazards of deep sea diving? Okay, deep sea diving. Okay, so there is oxygen. First there is nitrogen narcosis. Okay, nitrogen narcosis. So what is nitrogen narcosis? Is that nitrogen narcosis, if the gases are inhaled at high pressure, 100% you can, if you inhale 100% O2, it can lead to CNS depression. Okay, 100% O2 is lethal. Okay, it can lead to CNS depression. So to prevent this, a mixture of 20% O2 plus 80% of N2 is taken. This is taken, okay, for divers, okay, at high pressure. Okay, but at high pressure, at high pressure, at high pressure, this nitrogen produces narcotic effects. Okay, this nitrogen dissolves the membrane of your neurons, affecting the electrical conductance. Okay, reduce excitability of neurons. This has an anesthetic effect. Okay, and this causes tissue necrosis. Tissue necrosis. Tissue narcosis. Okay, then the problem is O2 toxicity occurs. O2 toxicity. Okay, so we don't usually take your pure oxygen. Okay, and dysbarism. Let's talk about dysbarism. Dysbarism is also called as your Caisson's disease. Caisson's disease. Okay, or your diverse paralysis. Diverse paralysis. Or your decompression sickness. Decompression sickness. Okay, this is your short note. Okay, important short note. So a diver who is working under the sea for long hours, if he suddenly comes, he is under the sea, but he suddenly comes to the sea level. Okay, suddenly comes. Okay, so he can develop the decompression sickness. Okay, so in the sea level there is high barometric pressure, high pressure. Okay, and large amount of nitrogen is dissolved. Okay, nitrogen is now dissolved in his body fluids, in his body fluids and his fat. Okay, but if it comes and there is low barometric pressure. Okay, then the nitrogen tries to escape, N2 tries escaping, but it doesn't escape. Okay, it can't escape suddenly, at the time is reduced. Okay, so there is formation of N2 bubbles, in the body fluids. Okay, and this N2 bubbles will nitrogen bubbles, okay, will block, these bubbles will block the blood vessels, okay, block the blood vessels, and blocking blood vessels will lead to ischemia and tissue death, okay. This N2 bubbles are very painful and will cause a pain in joints and muscles. Okay, and also affect your nervous system, by and cause your dizziness and paralysis. Okay, then temporary paralysis, not permanent paralysis. Okay, and the bubble formation will lead to chokes. Okay, okay, and this all can cause your diverse paralysis. Okay, what is the treatment? So for this decompression sickness, the treatment is hyperbaric oxygen therapy. Okay, your hyperbaric O2 and immediate recompression in a chamber. Okay, this can be prevented. How it can be prevented? By advising the diver not to come suddenly. Okay, gradual ascent can prevent this, or you can prescribe some inhalation of O2 He mixture before ascent. Before ascent, he can inhale O2 He mixture. Okay, before the ascent. Okay, what is scuba? Scuba is called as a self contained underwater breathing apparatus. Okay, which are taken by your divers. Okay, this carry a mixture of your O2 and your helium. Okay, so as to prevent your divers paralysis. Okay, so as to prevent your divers paralysis. Understood? And another clinical is the tuberculosis. This is caused by a mycobacterium tuberculosis. The causative is the mycobacterium tuberculosis. Okay, it increases the risk of drug resistance. What happens is that when there is infection of the alveoli, when the alveolar infection is there, okay, there is a mass of your granuloma. Okay, that will stay here. Okay, which will cause your appearance of your primary lesion. It will cause the appearance of your primary lesion in lungs. Okay, what are the symptoms you can see, like fever, malaise, loss of appetite, okay, cough, all this, cough, fever, malaise, loss of appetite, cough, all this. Okay, so these are your things which are given. Okay, and another thing which I want to discuss is your pulmonary function tests. Okay, what's the pulmonary function test? Another thing which is given is your exercise and what are the effects of exercise and all, but I am not discussing it as you have read in your your practical part. Okay, I am just discussing your pulmonary function test. Okay, what is auscultation? You know, auscultation is the for breath sound. It is important for diagnostic purposes where airflow is reduced. Okay, it is the hearing of the breath sound. Okay, and this inflammation of pleural membrane. Okay, this inflamed pleural membrane, pleuritis produces a sound which is called as a pleural rub. Okay, and this obstructive lung diseases, OLD, this can produce a sound which is wheezing sound, also can be heard without a stethoscope. Okay, let's not go into that. Let's talk about the pulmonary function tests. And pulmonary function tests are assessing for proper ventilation, if there is proper ventilation or not, to assess this, for proper ventilation of lungs, for assessing your gaseous exchange, and for assessing transport of gases. Okay, so for assessing your proper ventilation, you can you take the help of your spirometry. By measuring various lung volumes and all. Okay, you can measure your forced vital capacity, or your FEV1, FEV2 and FEV3. Okay, and all. Understood? And for assessing your gaseous exchange, you can find out your alveolar ventilation. You can find out your anatomical dead space, your physiological dead space. Okay, and your FRC. And for assessing your transport of gases, you can find the PO2, PCO2. Okay, of inspired air, of your expired air, or your alveolar air. Okay, and you can also take out the ABG analysis report, for assessing the acid base status of the body. Okay, understood? So after this okay, so with this we finish our respiratory physiology. Okay, this is done. Respiratory physiology is done. I have covered each and every concept, each and every part, each and every line of your Guyton textbook, as well as some few other extra points also. Okay, so we talked a lot today. about respiratory physiology. It is a lecture of about 3 hours 30 minutes, okay, 3.5 hours, and if in 3.5 hours you can revise the whole respiratory physiology, okay. So that's all in today's lecture, okay. I hope you enjoyed the lecture. I hope you got a good revision, like never before, okay. So if you like the lecture, do like, share and subscribe, and let's meet again in any other lecture, okay. Thank you and have a nice day. Good night.